Welcome, everyone. Assalamu alaikum again. And thank you very much for joining this meeting with us. So today our meeting agenda is two parts. Number one, we will discuss about the Mrcpch clinical preparation. How many time required, what is the qualification required, and what are the station, what are the marks, what are the pass marks, okay? Preparation time, okay? And I mean, everything related to your Mrcpch. And the second portion, we have 3-4 candidates ready. Dr. Bella, I think Dr. Batul, Dr. Shinash. So they are ready to give mock. So I will call one by one name, okay? And so before we start, do you have any question for me, anyone? Because once I start speaking, I'll speak and speak. So if you have any question, you can ask me now. This is the good time. Anyone? Any question? Okay. So this is my contact number. Why I am giving? Because in between, you will message me, madam, what is your number? So this is my number. You can take the screenshot. And below is my WhatsApp channel. Below is my YouTube channel, Mrcpch with Tamanna, which has crossed 6,000 subscribers. Alhamdulillah. In the world of Mrcpch, this is a great channel, not only for me, for you as well. I have started this channel in 2010, year 2010. But particularly for Mrcpch, I have shared this channel since 2017. So you can see there are last 5 years, 150 videos are uploaded. So you can see all of them. And there are part 1 videos, part 2 videos, DCH videos, and clinical videos. It will be helpful for you. And you can share this meeting, share these channels, whatever you feel it is right, okay? So now we will start here. See this. This is the exam circuit. You all know this exam circuit, right? Now, after COVID, the circuit has been changed. So the students who pass AKP before COVID, before 2021, they may not know the new system. So please be aware of the new system of Mrcpch clinical, okay? So the station is consist of, you can see how many station? Who can tell me how many station in Mrcpch clinicals?
10
Everyone,
stations.
why so? 10 stations. Very good, 10 stations. How many hours? Do you know how many hours the exam will finish? Do you know that?
3 years. 3 years.
2.5, not 3, 2.5. It will finish within 2.5. 30-minute maybe waiting time for like waiting outside. You will be in the exam hall waiting outside. That is 30 minutes. So total 3 hours. 2.5 hours is your exam, okay? So in this 2.5 hours, your future will be decided. So be very careful. Be very, very careful that before you go to exam hall, please have a good sleep, have a good bath, have a good pray, have a good breakfast, but not full breakfast, good breakfast. I did not say full breakfast, I said good breakfast. So the people who are traveling from one country to another country, for them, this is my advice. Please, please do not burden your head. If you go to the exam hall before 2 days of exam, just have a good sleep, have a good breakfast, hydrate yourself more and more, drink plenty of water. In between my exam, I used the toilet. Why? Because I drank so much water that I had to go to washroom. So remember, you can go to washroom even in between exam, no problem. No problem. Examiners are more than happy. No problem. They are very, very friendly. So hydrate yourself. Your brain needs hydration. Okay. Keep 1 candy chocolate in your pocket, 1 or 2 or 3. You can give to your patient. You can eat 1 for you as well. It will give slow release of glucose to your brain because you are hungry, you are down, you are feeling low, you are feeling down. So a chocolate or a candy will give you a little energy. So this is my advice as a senior, as a person who already passed exam, right? So there are 10 stations. We know 4 clinical. So clinical 1, 2, 3, 4. So if you start your circuit from here, you will go like this. But suppose if you start your circuit from here, then your circuit will go like this. Development, then history, then communication, you will get, then video, then clinical. I did not know before I went to the exam hall. Trust me, I did not know this circuit. I knew that there is a circuit, but I did not know that this circuit is a fixed. I mean, everyone will get this circuit. So if you start from video, you will get 2 video. Then you will start clinical. So you can prepare yourself that, okay, this is coming, this is coming, this is coming next. Am I right? So please take this screenshot of this circuit. This is very, very important to know what are your station and which after another. Which station is coming after one another. So this is the exam circuit. Every station is 9 minutes, you can see, except developmental station, which is 22 minutes, the highest mark. Developmental station contain the highest mark. And then the history taking is 22 minutes, it contain 10 marks. So developmental station and history taking time is same. You can see time is same, 22 minutes, 22 minutes, but the number is not same. Developmental station number is the highest. Okay, it is carries 12 mark and history taking is 10 mark, right? Then what? After that, what station? Who can tell me after history, what is the station? After history in this, because I will ask you question in between. So that you can communication. So there are 2 communication. Okay, there are 2 communication and you will get one after another. Communication, same number, 8 mark, 9 minute each. Then there is video station, 6 number, 9 minute each. Then clinical station, 8 number, 8 mark, 9 minute each. So if you remember, all the station are 9 minute except developmental station, which is 22 minute, and history taking, which is 22 minute. Times 2 means there are 2 station. Developmental station will be 2 station. One is red, one is blue, or one is pink, one is blue. There are 2 station. Like clinical 1, 2, 3, 4, there are only 4 station. Video 1 and 2, video A, video B, there are 2 station. But development and history taking, there are 2 stations side by side. So your friend, your colleague is giving exam. You are not giving that exam. Okay, so there are 2 station. 2 examiners are waiting for 2 history taking. So your history and your colleague's history will not be same. They'll be different. History, they will change. The examiner will change. You got my question, doctor? Whoever asked the question, this is your answer. Yes, red and pink. I can't remember the color, but there is 2 color. Okay, you should not bother about this thing because your history is 1 and your development is 1. Now, which station you will get, this is not your thinking. I mean, this is not your concern. Your concern is I will get 1 station for video, I will get 1 station for development, I will get 1 station for history. But there will be 2 different stations, 2 different examiners will take the exam. Okay. Now, areas of marking. Each domain has 2 marks. What does it mean? What do you mean by each domain? See, I am showing you the domain now. See, this is the domain. Okay, this is the domain. This is the domain. Domain A, domain B, domain C, domain D, and domain E. So each domain has 2 marks. Now you can ask me, madam, then why in video station it is only 6? Who can answer me? If each domain contains 2 marks, why in video station there is only 6 marks?
Because there is no assessment for history.
Yes, there is no marking.
Not all area will be assessed. Out of this, maybe 3 area will be assessed.
Very good, very good. Not all the area will be assessed. Okay, so in video station, which area will be assessed? Let me tell you. You will assess identification of clinical sign 2, clinical reasoning management 2, and physical examination part 2. There is no communication and there is no information gathering. But there is physical examination. Examiner will ask you, what are the physical sign here? Examiner will ask you, identify the clinical sign. Examiner will ask you, what is the management and investigation? Examiner will not ask you what advice you will give to the parents. Examiner will not ask you what information you like to know. But yes, there is a history portion in development, I agree. But for this history portion, they are merging with this. So there are 6 marks only for video station. Okay, because there is B, C, and D. There is no A, no E. So this is about video station. Now for communication, you can ask me, madam, for communication, why there is 8? Who can tell me which domain only has communication part? Which domain? Why it is 8?
Because no physical examination in this.
Very good. Excellent. There is no physical examination in the communication. Also, in the communication, there is no history taking, but some information will already given to you. So part A is given already, but there is no physical examination in the communication. Identification of the clinical sign, agree. I agree. There is no identification of the clinical sign as well, but the sign will be given to you that the child has non-blanching rash. So this is a physical sign. So there is no physical examination part in the communication. That's why communication contain 8. Okay. So remember, these domains are very, very important. This is made by Mrcpch. It is not made by Tamanna. So you can take the screenshot. Okay, this is made by Mrcpch, Royal College of Exams. They have this. Okay, so this is, there is 5 criteria. Information gathering. Okay, this is criteria A. Physical examination, criteria B. Identification of the clinical sign, criteria C. Clinical reasoning and management planning, criteria D. Communication skill, criteria E. So A, B, C, D, E. There are 5 criteria. So 5 into 2. Each domain contain 2 marks. Timing of the exam. Timing of the exam, there are, see here, timing is given. I already showed you timing. Clinical 1 to 4 station. So there are 6 minutes to examine the child and 3 minutes to discuss with the examiner. Development, start 9 minutes for history taking, 1 minute with the examiner, so total 10 minutes. And then 9 minutes for physical examination, and then 3 minutes for discussion. So 9 plus 9. So 9 plus 9 is 18. 1 minute discussion with the examiner. So 18 plus 1, 9. 18 plus 1, 19. And then 3 minute discussion. 19 plus 3, 12. Please don't write on the screen. I can see your name, Dr. Anirudh. The screen is showing your name. Okay, I'll keep you in the waiting room. Please don't do that. Okay. So clinical 1 to 4. Development we discussed. Development is 9 plus 1, 9 plus 1 plus 9 plus 9 plus 3. This is total 22 minutes. Now history taking, total 13 minutes with the mother. Total 13 minutes with the mother and 9 minutes with the examiner. 9 minutes or how many minutes? Yes, 9 minutes with the examiner. So 13 plus 9 is equal to 22 minutes. This is the longest station in your life. You will feel this is the longest station of my life, because the examiner will ask you each and everything related to that topic. It can be UTI, it can be bronchial asthma, it can be cystic fibrosis, it can be DKA, it can be child abuse. Am I understandable to you? Yes, anyone has any question, please ask me. Please open your mic.
Dr. Tamanna, pass mark 65 from 82 or 65%?
65 among 82. This is the pass mark. I will show you.
65 from 82?
82. Yeah, I'll show you again. I'll show you. Just let me finish this timing, then I will show you the pass mark. Okay. Okay, now the timing. Communication is 9 minute station. So total 9 minutes, you will talk with the mother. You will not talk with the examiner. Examiner is standing or sitting in front of you. There is one examiner. He is giving you mark, tick, 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 tick. I mean, which area you covered, tick, tick, tick. Criteria A, you covered. Criteria B, you covered. Criteria C, you covered, like that. Okay. So this is communication. Examiner will not ask you any question. In both DCH and Mrcpch, I have some candidates here, my DCH batch. For you, same thing. Okay, there is no difference between the exam. Just stations are a little different. DCH exam has prescription. DCH exam has data. Mrcpch does not have those. So the stations are little different, but the communication station is same, clinical station is same. No difference, okay? So in communication, they will not talk to you. The examiner will not talk to you. You will only talk with the mother. Now the video station. In the video station of Mrcpch, there will be two video A and video B. In the video A and video B, there will be two video. Usually video stations are, first of all, you will wait outside the room 1 or 2 minutes. Then you will enter into the room. You will go inside. And then the examiner will tell you, please sit down, see the video on the laptop. You will see the video on the laptop, 3 minutes. Then the examiner will tell you, stop the video, and then discussion portion starts. So it is 3 plus 6, total 9 minutes. So the discussion portion is 6 minutes with the examiner. Remember, this is the second largest station. You can think video is very easy, right? But video is the second largest station. What does it mean? Second largest station means you will be only with the examiner for 6 minutes. 6 minutes for you, maybe nothing. But at the exam time, you will understand what is 6 minutes called. It is really, really tough. And the examiner will ask you from head to toe, everything about the disease, everything. Okay, he will jump. He will not complete your answer. He will jump. So in this 6 minutes, examiner will ask you at least 16 questions. Every 30 seconds, one question. So you can imagine 16 questions from one video. So there are pretty good time you will be with the examiner, and please be prepared for the video a long time. You know what? If you give a chance, if you get a chance, a slot, and you failed, what will happen? There is a loss of financial loss, a big loss. Number 2, your hard work will be wasted. Number 3, you are traveling to another country. You are taking leave from your hospital. That time will be wasted. Number 4, you left your family for a few days. You are studying. That will be wasted. Your family will be sufferer. So that is the main concern of failing this exam. So do not go to the exam hall if you are not prepared. At least 50% you should be prepared. Okay, at least 50%. In my time, in Nepal Center, 7 candidates passed among 48. Okay, this is a very scary part. But I will not discourage you, but I will just advise you that Mrcpch clinical is just not like you are seeing the past test video, you are going to the exam hall and then you pass. No, nobody can tell like this. Okay, so this is the station development, history taking, communication, and video. I think we finished all station and clinical as well. So clinical, you will examine the child 6 minutes, 4 station A, B, C, D, and then you will talk to the examiner 3 minutes. So clinical is a very fast station. 4 clinical will give like within minute, because there is no time. There is no time. Asking only 2 or 3 or 4 questions, then there is no time. This is clinical, okay? Any question? Now I am giving a little pause. Any question? Anyone? Please ask me. Any question?
Ma'am, in clinical stations, would they ask us questions? Like what questions, or would only they will assess our clinical skills?
Yes, both the part. They will assess your clinical skill. If they think your clinical skill is not appropriate, you are checking the wrong technique. By wrong technique, they will assess you that how will you see ascites? Tell me, how will you look ascites? How will you look vocal resonance? How will you look vocal fragmentas? They will ask you. Okay.
Okay.
How will you check liver span? They will ask you. That is called
Okay.
clinical skill. And then they will ask you what investigation you do, what management you will do. So there are both.
Okay, so
both the-
right.
Right.
Would they ask us the DDs as well?
Of course,
Differential.
of course. What are the
Okay.
DD of this child? Of course, yes.
Okay, thank you.
Okay. So now each domain has 2 marks. We discussed. Total 82 is the pass mark. Okay, 82 is the total mark of the exam. Pass mark was 765 at our time. Write it down that it will change. At our time, pass mark was 62. Please remember, this was our time when I passed exam in our time. So when your time, it can change. Now you can ask me, madam, why this pass mark change? I know that you already passed part 1 and part 2. Did you? Everyone here passed already part 1, part 2. There is 175 candidate here, 175 exam candidates. So I guess all of you passed part 1 and part 2. Part 1 and part 2, was the mark fixed for passing mark? No, there was no fixed. Similarly, in clinical, there is no fixed mark. If the question pattern is very low, question pattern is very tough, pass mark is very low, then the pass mark will go down. But suppose question is very easy, maximum candidate of that center passed, then the pass mark will go high. Am I right? Am I understandable? Anyone has any confusion? Please, you can ask me. Okay. So our time, pass mark was 65 among 82. It may vary, as I said. There are 3 criteria: clear pass, pass, bare fail. What does it mean, bare fail? If you got 0 to 4 in a station which carries like 10, you got 0 to 4 out of 10. That is called bare fail. That is called 0 to 4 means what? Less than 50%. 0 to 4, bare fail. If you got 4 to 6, yes.
Each domain has 2 marks. If you please demonstrate each domain, how many domain, and domain means?
Domain means you missed the slide, right? I will show you the slide again. You missed the slide, previous slide.
Yes, yes.
Yes, okay, I will show you, no problem. So, Dr. Sambal Gaji, please don't write on the screen. Okay, so clear pass, pass, bare fail. So if you got less than 50% marks in any station, like 0 to 4 in 10, you will call bare fail. If you got 0 to 6, you will got pass. That means more than 50% you got in any station. So it is pass. Clear pass means more than 60%. This is clear pass. Wait, let me put someone. Dr. Ghazi, please do not write on the screen. There are 181 doctors. Please respect them. Okay. Okay. So there are 3 criteria: clear pass, pass, bare fail. So clear pass means you will get more than 6 in any station. Okay. So this is clear pass. If bare fail in one station, can someone still pass the exam? Yes. If bare fail in one station, he can still pass the exam. But if you got 2 bare fail, you may not pass. Because 2 bare fail means 0 to 4 in 10 number station. That means in 20 mark, you got only what, 6 or 8. So you will not cover the pass mark then. Okay, please, when I will ask you question, you can ask, because if you write chat, I can't answer you all the chat. Okay, please ask me question. Open your mic and then ask, please. That is better.
Ma'am, this variation in the pass marks is how much? I think it's little or much, like 60 to 65, not the 55 to 75.
Yes, yes. Vary means pass mark. Vary means it will go 67, 65. It will go, sometime it will go 70. Depend on the question. How many question is it hard question? Is it easy question? It depends actually. Okay, doctor?
Okay.
Okay. I think you're still not clear, right? Because your okay was not confident. It will vary. Pass mark will vary. It will go up and down.
My question is how much degree of variability? It is not much or it is very little variation?
Very little variation. Yeah, little variation. Still you did not get your answer.
I got. Thank you.
Okay. Thank you very much. So, doctor, who is asking the domain? This is the domain. I will not describe because I already described. You just can take the screenshot. This is called domain, okay? Domain A, B, C, D, E. Each domain contain 2 mark. I already finished this discussion. Domain A, B, C, D, E. Okay, doctor, who is asking the domain?
Okay.
Okay. Now, let us discuss about our station. Before the discussion of our station, there is some tips, okay? Some students message me for advice that, madam, I can't find any reading partner. I'm very alone. I'm working in another hospital. There is no pediatrician who is giving Mrcpch. What I will do? Remember, you will always find it hard before it's done. Okay. Mrcpch part 1, when I started Bangladesh coaching, okay, that time there was no coaching in Bangladesh. One coaching was there, but they only studied past test. They did not study any book. So I did not admit in them. So when I started my journey for Mrcpch part 1, it was very difficult for me. It was very difficult for me. I had to gather every material. I had to gather every material from here and there. Now the students are getting ready-made. My materials are being used all over the world, not only Bangladesh, all over the world. Exclusive my materials. So now it is very easy, getting very easy. But before, when I started, that time it was not easy. I had to collect each and every document for me and my coaching. Okay. So you will find always it is hard before it's done. Success does not come with ease. This I always tell the people. The successful people, they never get it easily. They got it by hard work. Okay. And now, next is, let us discuss about our history syllabus. Anyone has any question before I start history syllabus? Anyone has any question? Okay, no question. So, there are 3 kinds of history in Mrcpch clinical. Also in DCH clinical. I am not only discussing about Mrcpch, in between, I am also discussing about DCH. So that the DCH candidates can get benefit. History syllabus is 3 kinds of history all over the world. Acute history, convulsion. Chronic history, diabetes mellitus, uncontrolled. Acute on chronic history, cystic fibrosis with exacerbation. These are the 3 basic history types. Whatever history you read in your life, this will circulate. This 3 type will circulate you. Whatever the history you are, ask me any history, I will classify in this 3 category. Ask me, you ask me any history, I will tell you which category it is. So in my teaching, when I ask my students, I teach my students, I follow this criteria, that this is acute history or chronic history or acute on chronic history, because the management part is different. Management part is different, investigation part is different. Okay. So how we plan our study, how you plan. When you are preparing for Mrcpch, you can tell me, madam, how I take preparation alone. I don't want any coaching. I don't have that much time or that much money. So you will prepare this formula. By this formula, how you will prepare? Number 1, when you are reading history, you have to know the basic of history taking. What is the basic of history taking? Number 2, you have to follow 10-year recall, last 10-year recall. In our coaching, we usually follow this protocol. I teach my students from the last 10-year recall, so that when they go to the exam hall, they are not surprised. Okay. Number 2, for communication, you need to know what are the basic of communication. What do you mean by communication? Communication is not like you are talking with any person and, oh, I talked with mother, I passed. No, there are certain red flags. If you tell this point to the mother, you will get a fail mark. There are certain bullet point. If you don't say this bullet point, you will get half mark, bare fail, or only pass, not clear pass. So this bullet point and this red flag, you have to know for each and every communication style. Okay. And leaflet of NHS, there are plenty of leaflet. If you just type anything, suppose pyloric stenosis, or suppose DMSA scan in children, just type NHS leaflet, it will come. So you can type anything in the Google, it will come, you will download and you will read. There are 1,000 type of leaflet I have given to my course, 1,000 types of leaflet. Some are reading, some are not reading, some are passed, some are giving exam, like that. In clinical, there is basic. We have 2 kinds of class. In one class, I teach them the basic of clinical, right? Like abdomen. What is abdominal exam? How will you approach to abdominal exam? Like How will you approach to respiratory exam, respiratory system? How will you approach to thyroid? How will you approach to tall stature? So this is the basic. And then each system wise, we discuss from recall. That is called systemic examination technique. Like abdomen, we had one class for only abdominal cases. We had one class for only respiratory cases, like that. If anything new comes to the question, to the exam, we directly add them. We directly add them to the course. So it becomes rich day by day. Okay. Areas of focus. Now you'll tell me, madam, where I will get the material, how I will take preparation, where I will find all the resource. Mrcpch with Tamanna, that is the YouTube channel. I upload for some few moments, few hours I upload, because these are recall, okay? If I upload this on the YouTube, think about that. If examiners are seeing this or someone, they may think that why Tamanna is discussing this in front of the world. Our discussion is private, right? We are discussing privately. So we cannot see in front of the world, right? So we give few materials, few videos, okay? There are lots of YouTube channel. In Mrcpch, there are lots of YouTube channel. Like there is London School of Pediatrics. You can write it down. London School of Pediatrics. They have plenty of video. Then past medicine, past test, they have plenty of video. Okay. They show this video free. So you can see respiratory exam, cardiovascular exam, abdominal exam, communication technique, developmental technique, but there is a but. Those videos are 10 years, 15 years older. So when you see those videos, they are 15 years old or 10 years old. So the problem is some of those videos techniques are now obsolete because exam pattern is changing every 2 or 3 years. Pattern is changing, timing is changing, questions are changing. Am I right? Last 2 years, the questions are coming very, very different. I mean, in last 2 years, because I am following last 10 year recall. I know because I'm preparing last 2.5 years, I prepared for Mrcpch clinical. So the question pattern is a lot of changed. So if you see those videos, the problem is you will not know the recent one. Okay. Books, as I said, Mrcpch, very good. Rebecca for communication, but very, very old. Rebecca is written in 2008 or 10, I think. Now in 2023, in this last 13 years, a lot of NHS leaflet has been changed. NHS leaflet, NHS treatment, NHS advised has been changed. For example, acyclovir is the treatment of nephrotic syndrome with chickenpox. Before 3 years or 4 years, did you know this thing? No, you did not know, because this guideline came in 2019 only. 2019, this guideline came that a child with nephrotic syndrome, we don't need to give varicella zoster immunoglobulin. If the child has some immunity, we can give half dose of acyclovir from day 7 to day 14 exposure. This information before 2019, you did not know. So those videos, those books of Mrcpch which are written before 2019, they will miss this information. They will not tell you this information because nobody knows this information, right? So remember, old books has a problem. Old video has problem. You have to know the recent update. Okay. So Mrcpch, Rebecca, Clinically Secret, that is Malaysian book. You will find it in my Telegram channel. Okay. So there is one channel dedicated for all over the world. That is Mrcpch with Tamanna in the Telegram channel. Okay. This link you will find, if you ask me, there is lots of group who know this channel. Your friend know this channel. Might be not telling you, but they know this channel. Mrcpch with Tamanna Telegram channel. I can tell, touching in my heart, that everybody here, they know Mrcpch with Tamanna channels. Okay. So Mrcpch, Rebecca, Clinical Secret, Khidir History, NHS leaflets. Very, very important. Khidir History is a good book, but what is the problem? Who can tell me what is the problem in Khidir History? This is old. There are plenty of history which added after the Khidir book. I will discuss today one history. you will see that history is not present in Khidir book. NHS leaflet and guideline. So NHS leaflets are very important for communication, for clinical, and for history taking. So please read NHS leaflet and guideline. Guideline has no alternative. There is no alternative of guideline. Okay, you have to read pediatric guideline, you have to read clinical neonatal guideline. Remember, in last exam, there were neonatal video station. So from the neonatal guide, you will find neonatal video, you will find neonatal communication, you will find neonatal history taking. Am I right? Now, what is next? Summary. Summary
Ma'am,
of-
guidelines are nice guideline or NHS guidelines?
They are same, my dear. NICE guidelines and NHS guidelines, there is no difference. We have green book
But in
of pediatric. We have
yeah,
green
hey,
book
but
of-
that is some hospital's name written. It's not nice guidelines.
It is the NICE guideline. Hospital name written means these trusts are using this guideline. That doesn't any matter. Matter is that is our book. Okay.
Okay.
Dr. Taman, I think she
PIP
is
is-
asking about patient info. So this patient info also from guideline or there is another source?
In England, there are different organizations like NHS, Royal College, different trust, patient info, London School of Pediatrics. These are all following NICE guideline. Whatever you are reading, partner in pediatrics, green book and neonatal book, whatever you are reading, partner in pediatrics, that is NICE guideline. They are all following the same guideline.
Okay,
Okay.
madam. Thank you. Thank you.
Some student ask me, now some answer for your question. Some student ask me, madam, I'm very alone. How can I take preparation? Remember, birds who fly high, they fly solo. Whenever you are alone, you are doing it alone, nobody is helping you. Remember, you will go very high. You will fly so high that you don't need any help. Okay. The birds which are flying in the lower layer, they have many company. They have many companion. You will see they are flying in group. But the bird who is flying very high, they are alone. Because you need more strength to go in that position. So never ever think you are alone. Okay. Hard work has no alternative. I always tell my students that hard work is no alternative. A person who is not doing hard work and a person who is doing hard work, there is a lot of difference between them. Okay. Now our session is finished. Anyone has any question before I start communication with Dr. I think Batul. Dr. Batul is here.
Ma'am, can you please tell us that shall we start reading from a single book or how shall we start preparing for it for the clinicals?
Okay, you will start from Mrcpch. Okay. And communication NHS leaflet you will download from Google. Okay. For clinical,
Okay,
Mrcpch is the best book. Yeah. And for I can tell you one thing. I'm not telling you that do any course. I'm not telling you that. But I'm telling you, course is organized. Any course you join, they are organized people. They are not like haphazard people. They are very organized people. They have organized it for you. So reading things here and there is one thing, and get an organized course is another thing. You got my point? So if you ask me, madam, tell me everything, I can't, because I have a limited time. Okay. I just can give you advice that please read Mrcpch, please go to NHS leaflet, download from the Google. Okay. And please share and care. Share the meeting or discuss with your friends about the meeting. Okay. The more you share, the more you care, and the more you will get prepared. And you need a good group, actually. You need good 2-3 friends. They will help you in pass. Okay. So let us discuss our candidate. Who messaged me? Yes.
Yes, thank you so much, Dr. Tamana. I wanted to ask, in place of the Kader book and the Rebecca book, what other books can you suggest that are recent that we can read for the communication
Recent
sessions?
Malaysian is good. No, communication, there is no recent book. I am sorry. There is no recent book. NHS leaflet is the only leaflet. There is no recent book for communication.
Okay, what of for the Malaysian book? Is there any recent
Yeah,
book
there
that
are
we
some
can use?
communication. Is there are some 2, 3, 5 communication in Malaysian book. Yeah, only 5 or 6 like that.
Okay, thank you.
Okay, welcome.
Thank you.
Any question?
If yes, thank you. If we search NHS leaflets in Google, will we find all leaflets of all systems, and then we can download, or we will have to search system wise?
What does it mean, doctor? Which one? Which one system-wise, doctor?
GI system or cardiology system or nephrology. If we search NHS leaflets in Google, then will we find all system-wise leaflets in one place, or we have to search separately about system-wise in Google?
No, no, separately. Whenever you are reading any topic, just search in the Google.
Okay, okay.
Dr. Rifat, are you here, Dr. Rifat?
Yes, I'm here.
Okay, okay. So this is your station, Dr. Rifat. Okay, what is the next question? Until Dr. Rifat is getting ready, what is the next question?
Madam, regarding video station, from where we will get these videos and plus explanations?
From where you will get? First of all, you will have to know what video is coming in exam. Okay, there is a question bank. Okay, follow
Yes.
these free meetings. Follow this free meeting. In the free meeting, we discuss. Follow Mrcpch with Tamanna channel. Mrcpch with Tamanna channel has some video station. Okay, and
Okay.
if you want to join any organized course, you can contact on my WhatsApp. Okay.
Thank you. Thank you.
Thank you. Any other question, doctors? Better if you ask me by opening mic. Dr. Rifat, when you are ready, tell me, okay?
Yes, just 1 minute.
Yeah, yeah. Any other question in 1 minute? We can answer any one more question.
Dr. Tamanna,
Mm-hmm.
I just wanted to ask about the waiting time. Like, what is the expected waiting time after you pass your AKP to get a seat for a clinical examination?
Okay. For me, it is difficult time because, you know, I was in the COVID era, right? I waited almost 3 years to get a clinical seat, one clinical seat. I just got one seat and I passed, Alhamdulillah. If you fail, then there is another 1 year waiting time like that. So now the waiting time is reduced. It will not take 3 years. Now the waiting time will be 1.5 years, almost. Okay, Dr. Tufail, is this your answer?
Yes, I got the answer. Thank you.
Thank you.
Okay.
Mm-hmm. So
I
Your
just
time
want
is-
to clarify the scenario. So what I got in the scenario that Trina has discharged from the OPD, Daniel, and in the later part of the day, he got readmitted in the PICU with the unstable condition. And now I have to talk to mom.
You are the registrar. You are not Trina.
Yes,
Okay?
yes, yes. Yes.
Okay.
Yes, but the boy had seen in the OPD in the morning and later on he got admitted.
Yeah, Trina's you the boy. Trina is your junior.
Okay. Okay.
Okay. Start, please. Your time starts now.
Okay, so good evening, mom.
Good evening.
I'm Dr. Ifat Matloob, one of doctor here. I believe you are Daniel's mom.
Yes, doctor, that's me.
Okay, so ma'am, I'm really sorry to meet you in such a difficult time. And I'm here today to talk to you about Daniel's condition. Do you
Doctor,
want anyone else to
start? Doctor, before you start, let me finish. Before you start anything, how to complain about Dr. Trina? I just want to complain about her, okay?
Okay.
Now
Okay, so today I'm here to talk to you about the Daniel's condition. Do you want anyone else to join the meeting or shall I start?
No, doctor, you can start. There is no need of anyone. I'm here for
Okay.
my child.
Okay. So, ma'am, first of all, please tell me that what do you know so far about Daniel's condition?
You are telling me what I know. My child got
Yeah.
rash, and your doctor Trina, she discharged my child without doing any investigation, and now my child is dying.
I'm sorry for meeting you in such difficult time, and I appreciate your worries. We are here actually to support you and to help you out, and we are here for the Daniel in every circumstances. So, as you know, ma'am, that Daniel had rash and he is sick, so he need admission in the ICU. Okay, so is it clear?
He is already in ICU, doctor. He is dying, doctor. He is in his last breaths.
Let's hope for the best. Daniel is sick, he is critical, and we are doing our best. Okay, so let's hope for the best that he will recover. And we are going we had already started our treatment. We are monitoring heart rate, blood pressure, his urine output. We are giving him medications, and we had antibiotics, and we send all the necessary blood tests as well. Plus, we are also involving other doctors like the infectious disease doctor, who will give their expert opinion if needed. And whatever the treatment Daniel needed, we will give it. So, am I clear myself so far?
Yes, you are very much clear, doctor. But doctor, I have no trust, no faith on your hospital, okay? Your hospital has doctors who discharge this kind of children who got admitted in ICU after 4 hours. Okay, so I don't have any faith on your hospital. I want to take my child back to another PICU. Okay, please make it discharge. I want to go in another hospital. I will go in London. I'll not stay here. This is a district hospital. I'll not stay here. I'll go in London. I'll go in Evelina. Hello, Dr. Dr. Rifat, your mic is mute.
Oh, okay, sorry. So, ma'am, we are here to clarify all your queries one by one. Okay, and first of all, I will tell you that we are best hospital for the Daniel, as we know his condition from the beginning. And although it's your right to go to anywhere, but first let's stabilize Daniel, and then we can discuss with our consultant if you want anywhere. We are trying our best to save his life. Okay, and is it am I clear?
You are very much clear, doctor. But am I clear to
Okay.
you? I do not want to stay
Yes,
in
you
this.
are clear.
Am I clear?
Yes. Ma'am, you told me one of your concern that the Daniel had visited and then got discharged. So first of all, let me explain to you that there are certain conditions in which the signs of the disease, they are not developed fully on the beginning. And within short period of the time, they get deteriorated and ultimately they end up in the ICU, like in the Daniel condition. So in 4 hours back, he might have only rash, okay, and he does not have any other sign at that point in time. So, but the disease course, it is such that it end up in the critical situation. So if we go back from 4 hours back, at that time there was no such red flag sign or danger sign was there. So I'm so sorry for that Daniel is passing through this disease, and we are with you. Uh, so these are your two concerns. One was the discharge and the other was you want to go to other hospital. Is there any other concern that I can address?
No, doctor, you are very much right. My child may not have sign symptom that time, but you should not discharge any of these patients. Am I right?
If the patient have rash, we should tell the red flag signs to the parents or the caregiver that if the patient develop any such of sign, then immediately come back to the hospital. Okay, so
Okay. I'm
you
very much happy with your explanation. I'm very much convinced, but I want to make a complaint, formal complaint about Dr. Trina, and I want a discharge.
Ma'am, it's your right to complain about any of the staff member and any issue. I will guide you to the patient advisory liaison service for that. But it's in best interest of Daniel. He is so sick and critical that during even the traveling or the transfer, he may not able to make out. So just trust on us. We are doing best for him. Let us stabilize him first, and then it's your right, you can go anywhere and we will support you. We will make summary and we will do anything, and we will make a meeting with our consultant too. So it's our advice that first let us stabilize Daniel, and then you can decide.
Okay, doctor. Thank you very much for your time. 6 minutes, okay, Dr. Batul, 6
Okay.
minutes.
Okay, so ma'am, I will quickly go through the what we have talked about, just to make sure that we are on the same page. That today we talked about Daniel's condition, his critical condition. What are we doing for him? And I have addressed your concern about the discharge early in the morning, and what we can do for Daniel and for you. So I will give you some information leaflets and trusted websites so that you can know more about Daniel's condition, and it will help you out. Is there any other concern?
No, it's fine, doctor. Thank you very much for your time.
Okay, thank you so much for your time. If you have any query, then you can come to us at any time.
Okay, thank you. Well
Thank
done.
you.
Dr. Rifat, sorry, I misinterpreted your name. Dr. Rifat, what is your idea about the communication? You did how much? You did well?
I think it's okay. It's not, it's pass, it's not clear fail. It's in between.
Okay, any mistake you did? Any major mistake you did? No.
Maybe I
No.
was not much confident about the when I was defending.
Okay, again, open your mic, please. I had to mute everyone. Yes, sorry.
Okay, so I was not much confident when I was defending my junior.
Yes.
So
I will say, Dr. Rifat, you did well. You did very well. At least pass mark you will carry, because there is 2 or 3 red flag in this scenario. Okay. One red flag, if the doctor said that, I don't know why Dr. Trina discharged your child. This is a red flag. If you say this red flag, you will fail on this station. Because when there is, really slow, doctor. When there is some
Repeat this point. What was the red flag she missed?
red flag, she did not miss. She defended Dr. Trina's condition. She defended why Dr. Trina discharged. If she said like that, I don't know why Dr. Trina discharged your child. I don't know. I have no idea. I was not present there. That means you are a not good team member. I'm very sorry, doctors. Okay, so remember, there is some red flag in the communication that you have to defend your team. Okay, so you have to know that your team, whatever he or she is, they can be wrong, but you cannot say, you cannot prove them wrong. Trina is a junior. She discharged a patient who has non-blanching rash. Trina is new to NHS. Only 1 month back, she joined and there was an induction period for her. She just joined. She did not know that in every patient of rash in NHS, we observe for 4 hours, we give investigation, and then we discharge. Okay, Trina did not know this rule because she is new to NHS. It is very, very easy for her to do mistakes. So remember, when there is any mistake happen, okay, it is definitely our team's fault because one of the doctor who discharged a non-blanching rash, sorry, a blanching rash, it was blanching, but she did not order any investigation. So mother is furious. Why did not you do any investigation? Dr. Rifat, she defended that time the child was discharged, that was blanching rash, normal viral rash. So we gave paracetamol and then we discharged. Soon after this, blanching type of rash will become non-blanching and it is meningococcus. So the child rapidly deteriorated and within 4 hours, again admitted with ICU support. Why ICU support? Because the child was in shock. Now, this is definitely our fault. So we have to say repeatedly, sorry, sorry, sorry. But you cannot say it is Trina's alone fault. It is our own fault. It is the fault of our team that we could not teach her properly. Okay. So remember, whenever there is any mistake, you will say sorry, but you will not defend, or you will not go against your team. This is a red flag. If you said that what Dr. Trina, why discharge? I don't know. I was not present that time. It is a red flag. Okay, but Dr. Rifat, she did very good. She did not say that. She said that when we discharged, that time rash was. Please, doctors, mute your mics, please. I cannot talk. Okay. So Dr. Rifat did very well, number 1. So whenever we are doing any communication, doctors, let me tell you the basic structure of communication. Then you will understand how the communication actually runs in our exam. Number 1, hello, good morning. So this is introduction. Hello, good morning. I am Dr. Rifat, one of the registrars there.
Dr. Tamanna, I have one question. I'm sorry. I have one question.
Yes.
Hello?
Yes, yes.
Dr. Tamanna, I did not get this point that when a team member, a junior doctor is doing mistakes, so we do not have to defend her, or have to at the same time just put her in front of her, blame her. Both the things we should avoid.
What I said that if you said, I don't know why she discharged, that is a red flag. That is dangerous. She defended.
That is red flag for failure. Dr. Tamanna meant that red flag is for failure. If you're saying that I don't know that why she did discharge the patient.
Yes, this is the red flag for communication. This is not, you should not tell this line. That is what I said, Dr. Bella. You should not tell this line. Oh,
it is.
Okay, I'm making it easy for you, Dr. Bella. What Dr. Rifat said, that is appropriate. Dr. Rifat said this line that That time the rash was non-blanching, so it was benign rash. Dr. Bella, your mic is mute.
Yes. Yes, Dr. Tamanna.
Dr. Rifat did right. Okay, she did right. She defended her junior.
But the junior did mistake, so defending is not good.
Defending is good. I say defending is good. Not defending is not good. I say defending is good. You have to defend your team.
So we should not apologize.
Yes, you should
we are sorry
apologize.
that.
You should apologize. You should apologize. But you should
Then we say
defend.
that it was a mistake by a junior doctor that he discharged without
No,
taking a senior
you cannot
consult.
say that. No, you cannot say that. Because in the guideline, it is written that if the child is ill looking, okay, with rash, you must observe for 4 hours. Maybe Dr. Trina misdiagnosed. She diagnosed it as measles. So she discharged. She did not observe a measles case, or she did not observe a rubella case. Because there is guideline, measles you should not admit unless there is pneumonia, encephalitis. You get my point, Dr. Bella?
Yes, yes.
So this is not a mistake by Dr. Trina. What Dr. Trina does, she did discharge because she did not think that it is going to be meningococcus. You should apologize. What happens to your child? On behalf of our team, we are sorry for that. But you should not say, why Dr. Trina discharged, I don't know. This is her mistake. I don't know. This is a dangerous point. That's what I said, okay? You should apologize, definitely.
Okay.
And Dr. Rifat apologized. Dr. Rifat said, what you are going through, I'm really sorry for that. Okay. And Dr. Rifat defended the colleague that, yes, she was in a state of good child. There was no current indication for admission. Okay, you are right. Okay. Now let's point introduction. Okay. So I will introduce myself, then I will make some rapport. I will clarify my role. Hello, good morning. I am Dr. Tamanna. This is introduction and rapport. Then clarify your role. Clarify your role means I am one of the registrar in this hospital. Clarify your role. I am one of the registrar in this hospital. Then after this, clarify your role, you have to ask, am I speaking to Jack's mom, Amina, or whatever? Am I speaking to Jack's mom, Amina? So you have to ask whom you are talking to. Then after this, you have to tell again some part of rapport. Yes, doctor, I am Amina, Jack's mom. Again, rapport, you have to make some rapport that, nice to meet you, mom. But in this type of scenario, when there is critical incident, please don't say, nice to meet you. Say, thank you for coming to us. Don't say, nice to meet you here, please. Say, thank you for coming to us. Because if you say, nice to meet you, the mother will say, I am not nice to meet you, doctor. It is not a nice time. You could say, thank you for coming to us. Okay. Then you will say about agenda and then prior knowledge. What is agenda? So Mrs. Amina or Amina, we are here to discuss about Jack's condition. Okay. Jack had blanching type of rash, which soon becomes non-blanching. And Jack is now admitted to PICU. Okay, doctor, am I right? Doctor, am I right, Amina? Here, Dr. Rifat did one mistake. She said, how far you know about Jack's condition? This is not a history taking. So you cannot ask. The agenda is given to you, Dr. Rifat. The agenda is the rash was blanching. Soon it became non-blanching. So you have to tell mom the agenda. I'm here to discuss about Jack's condition. Jack had blanching rash in morning. Soon it became non-blanching rash and now Jack is admitted to PICU. Is that correct? Is that okay, Amina? Yes, doctor, I want to complain about that, Trina, Dr. Trina. Yes, I can totally understand how frustrated you are. I can totally understand your frustration. This is called validity of emotion. When any person is talking about their frustration, you have to talk that their emotion is valid. Their emotion is valid. Okay. So yes, I know how frustrating you are. This must be frustrating for you as a mom. Then you have to say sorry. On behalf of our team, we are really sorry that this thing happened to you. Dr. Rifat said one time sorry, but at least 2 or 3 times you should say sorry, because this is an apology scenario. So you should say 2 or 3 times sorry, Dr. Rifat. You said one time, but if I were you, I will say 2 more times sorry.
Okay.
Okay, because this is actually our mistake. The doctor, Trina, she knew. So she discharged without any investigation. She thought it is a case of measles. Okay, so this is the lack of knowledge to Dr. Trina, and this is our team's failure. This is not her failure. This is our team's failure. Okay, so ask about the mother, then agenda, then prior knowledge. How far you know, mom? How far you know, mom, this condition? Ask about the prior knowledge. Okay, don't ask like that. How far you know about Jack's condition before the agenda? Come on. Okay, so doctor, this is the main agenda. So before telling the agenda, you can't say how far you know, because the mother will tell you the full history and you don't have that much time for full history. Okay, this is one point. Then Dr. Rifat did very well. She excused, but at one point when the mother is crying, Dr. Rifat said, I'm offering you a
One should
tissue.
offer tissue or water. Yes.
Yes, you offered, I know. I know, I know, I'm saying that you offered. She offered me a tissue and she offered me a glass of water, but I found that was robotic voice. I am offering you a tissue. I'm offering, you should not do that in the exam hall. Oh, Mrs. Amina, I'm really sorry for that. You should have a sympathetic voice, Dr. Rifat. Do you need one glass of water, please? Shall I give you a tissue, please? Okay, Dr. Rifat. So see, my voice has been changed, isn't it? There is a fluctuation of the voice.
Tone in the way.
Tone is the main thing, you know. Same thing you will tell in a tone, and same thing you will tell in a different tone. It will make different, totally different. So when you are offering me a tissue and water, I find less empathetic. Okay, so you have to say like that. Oh, I'm really sorry. Okay, do you need any glass of water, please, or any tissue? Just offer. Don't say I'm offering. Don't say. You are not a robot. You are a human being, and she's crying in front of you. You know, in our hospital, when someone is very upset, everyone goes and hug them. But in exam, you cannot hug them. But at least in your voice, you can tell, oh, I'm really sorry for that. She's crying in front of you, okay? So at one point, Dr. Rifat, I found a little less empathy. Otherwise, your voice is very good, excellent. You have empathy, but that point, I find it is missed. And the sorry, you said one time, but I think you should say 2 or 3 more times. And when the mother is saying you, I'll go another hospital. Okay, first of all, you should say that, ma'am, a formal incident report already has been done and our consultant is informed. If you go to any other hospital, you are more than welcome. But if you go to Evelina, what they will do? They will first take history from you. Then they will admit Jack, and it will take a lot of time. Jack is in shock now. He needs double channel IV canal. So we can't discharge him now for Jack's betterment. So it will be very, very bad idea when we discharge Jack in this condition. Let him stable, then you can go in any hospital. But let me tell you, if you go to Evelina, they will take full history from the beginning and they will start from the beginning. They will not immediately admit you. They can't do that. Okay, there is a shortage of everything in the Sorry, doctors, my voice has been gone, I know. Am I audible now, everyone?
Yes.
Yes.
Sorry, it's for a moment, the condition.
Yes.
So,
doctor.
Dr. Trina, you are not defending her, but you cannot blame her as well. She is new. So you have to say repeatedly sorry to the mother. On behalf of our team, we are sorry. The incident report has been made. When the mother is saying, I'll complain, you will say, I will guide you to the PALS, patient advice and liaison service that Dr. Rifat did, but you missed incident report and you missed that our consultant is already informed about Jack, about Daniel. Okay, and Daniel is in best care of our hospital. If you go to any other hospital, the condition will be same. There is no difference in management in UK. Every hospital, once mother said, I want to go Evelina, because you are district hospital, you know nothing. So you have to say, Mom, our hospital is the best hospital in NHS, according to management of this child. And all the hospitals in NHS are same protocol, following the same protocol. So wherever you go, the treatment will be same. Am I right, Dr. Rifat? So these things you have to say to the mother. And I did not see any major mistake, Dr. Rifat, just a little brush up. Okay. Lastly, when you say thank you to the mother, you have to say some nice words like, I wish speedy recovery, or I wish Jack recovers soon. And I am really sorry for what you are going through. So lastly, say again sorry and say the mother that I want Jack's speedy recovery. These two lines are very, very important. Last line. Okay, Dr. Rifat? Hello, am I
Yes.
audible? Again?
Yes. Yes.
Go on.
Yes.
Yeah.
Yes.
Okay, okay. So anything, Dr. Rifat? Any question from your side for me?
Yes, as you said that in NHS there is a rule, any patient with rash have to be observed for 4 hours. So any
Yeah.
blanchable and non-blanchable both?
Both, yes. This is guideline in the green guide pediatric guideline. Rash in pediatrics. You will see there is a chapter in green pediatric guideline. Any rash that comes to the pediatric department, you should observe at least 4 hours. Okay. Even if it is
Okay.
measles, even rubella, yeah.
Okay. So
Okay,
thank you so much
doctors,
because
thank you very
I know the things, but practically
Now-
actually it makes difference when you are doing it. Thank you so much for giving me chance.
Yes, yes. Welcome, dear. You are most take care of the baby crying. Now, Sheena, she is here. Dr.
Yeah,
Sheena?
ma'am, I'm here. Yes, ma'am, I'm here.
Dr. Tamanna, your voice breaks.
Your mic is mute, Dr.
Ma'am, can you hear me? Bits and pieces, your
Yes,
voice
I
is
can.
getting cracked.
I can hear you.
Yes,
I
ma'am.
can hear you.
Hear.
Okay, okay.
Yeah.
So this is your case, Dr. Shinash, first case. Communication, okay? Talk to a father, Mr. Robert, about his son having nephrotic syndrome. You
Maybe
call
screen is
them.
not changed yet.
Oh, screen is not visible. Okay, okay. Sorry for that. Now?
Not yet, ma'am. Yeah.
Okay, okay. So read this scenario, Dr. Shinash.
No.
Okay, some doctor is asking me question. Please, can you open the mic because all the question gone. When I log out, all the question vanished. Can you open the mic and tell me the question? Ask me the question.
Hello.
Hello.
Yeah, I was wondering whether we can also offer some clinical psychologist support if the mother was too upset and the family are grieving and is not able to tolerate this trauma. Can we also offer some clinical psychologist support from the hospital? That's what I was wondering. If we can
Yeah.
include that in the communication. Thank you.
Yeah, I never did that actually in my life. I mean, never heard that actually. That because psychological support we give in chronic conditions, like a mother whose child has autism, we gave cognitive behavior therapy for mother and the child as well. Suppose a child of ADHD, cognitive behavior therapy for mom, for child. Okay. For acute condition, mother is furious. Okay. Mother is furious. Mother is angry. You can refer them to PALS, patient advice and liaison service. This PALS does not always mean complain. Remember, PALS means patient advice. And service. So patient advice, that advice will be given by a group of people. They are called PALS people. Am I make yourself clear? So when there is any acute condition, you will refer this patient to the PALS. Not for complaint, also for support. Mother is upset and his child now in shock. Think about you. You will be also upset. Like, so in this patient, I will not offer any psychological support, but I will offer patient advice and service. They have some counselor. You
Ma,
can,
please, your
question
voice is
correct.
breaking. We didn't
In
get what you
PALS, there
said.
is counselor. Okay. Really?
Yeah, I got it. Yeah,
Really?
thanks. Thanks.
Ma'am, please, your voice is breaking so much. We didn't hear anything you said.
And because
Can't hear you, ma'am.
I'm really this trouble. Actually, I have the network is like that. Something. Hello. Am I audible now, doctors? Can anyone
Yes, ma'am.
confirm?
Yeah,
Yes,
better now.
Okay, okay, it's better. I changed this network. Sorry for this trouble, actually. Okay, so Dr. Shinash, you start. Okay.
Ma'am, just one thing. This is like he's exposed to chicken pox.
Yes, he's exposed to chickenpox patient.
Okay, that is from the hospital, ma'am, because he's upset.
And when he was admitted, there is one
Okay.
child, okay?
Okay.
He was
Okay.
playing with
Okay.
that child. Yes. Okay, you start. Your time starts now.
Yes, ma'am. Okay. Hello, Mr. Robert. Am I audible, ma'am?
Yes. Hello,
Yeah.
doctor.
Hello, Mr. Robert. How are you doing?
Doctor, I'm fine, doing fine, but you called me emergency to bring my child to hospital, and I went to office, doctor. What happened, doctor?
Yes, I'm sorry about that, Mr. Robert. I'm Dr. Shinaz with you. I'm one of the doctors who was treating your child. Thank you for coming to us. I know it's been a bit difficult for you to come to us again. So, Mr. Robert, I just yeah, do you have any idea why you have been called back?
I know that Jack has been diagnosed with nephrotic syndrome, and I know that.
Hello.
Yes, doctor.
Yes.
I know that my child has nephrotic syndrome and he was discharged. So I don't know, doctor, why you called him again.
Yes, Mr. Robert, I'm sorry about that, but actually things as you know your child has nephrotic syndrome, and we have started this treatment for him. I want to convey to you that unfortunately there has been a small contact with a case of suspect chickenpox when he was admitted in the hospital. So actually, the thing is now the Robert is your son is on actually steroids, which is a medication which we are using for nephrotic syndrome. This decreases the immunity of your child. So that is why during this, when the child is not having enough immunity, there is a chance that he may get infection very fast. So a child who was next to your room was having chickenpox. The problem is in chickenpox, sometimes early symptoms may not be clear of chickenpox. So when he was admitted with your son, he did not have clear picture of chickenpox. But after your discharge, after one day, he developed the rashes and which are very characteristic for chickenpox. So in this condition, in this state, we have to give him some medications because as he is on medication which decreases his immunity, so we have to give. So he may develop severe chickenpox. So to prevent this, we have to give him some injections, and we have to keep a close watch on him if he is developing any symptoms of chickenpox. Are you getting what I'm saying, Mr. Robert, or am I going too fast with you?
Doctor, you gave me 100 information in one breath. So let me absorb this information. So doctor,
Okay.
as far as I understand that my child has got some contact with a chickenpox child. My first question is, doctor, why you did not prevent my child to mix with that chickenpox child? This is my first question. He was under you, doctor. Why did not you prevent him?
Yes, Mr. Robert, I'm sorry about that. Actually, yes, I understand your concern, and it should have been done. But usually, the patients who are like chickenpox, they are kept in separate isolation rooms. But sometimes some children they do not develop the symptoms of chickenpox on the day first. So that is why. But they have the virus inside them, and this virus they can transmit. So unfortunately, this child was having symptoms of chickenpox on the second day after the contact with your son, Mr. Robert.
Okay. So I understand. Okay, there was no sign symptom. But
yes, Mr. Robert.
Now I think, doctor, you need to do some test for my child that my child is really having this bug, chickenpox bug on the body or not.
Yes, Mr. Robert, we can do some blood tests, but if it is very early, sometimes the blood test may not come positive, but we have to give him some medications which may help to prevent him from getting this infection.
Okay.
So if
what is the medicine you use, doctor?
It is called as immunoglobulin.
Immunoglobulin you will give my child, doctor? What is that, doctor? What is that drug, doctor? That medicine, doctor?
See, Mr. Robert, we have we have any jabs. We have two types of jabs. one of the jab will affect immediately after giving, and the other jab which you usually give in the when the jack has received during his childhood, those jabs actually work after some days. This is like a jab only, but this jab works immediately after giving. So this will prevent the infection from coming to jack.
Okay. So you will give jab to my child now or oral medicine? What you will give?
This is like a jab, but this is an injection actually. This is the effect of this. This is actually an injection which is to be given through the bloodline, but this acts like a jab.
Is there any side effect, doctor, about this medicine, whatever you are giving through blood channel? Is there any side effect of that drug?
Yes, Mr. Robert. Unfortunately, there may be some side effects, but these are well controlled. Sometimes some of the children may have allergies to this medication. If he has an allergy, we will treat him with anti-allergic medications that we have. Some children, they develop some headache with this medication. Some children also develop some minor fever, but these symptoms can be managed with good amount of taking fluids and some painkillers which he can take.
Okay. Okay, doctor, 6 minutes. Okay, Dr. Shinash.
Yes, doctor. Yes.
Okay, doctor. So is there anything we need to prevent future? Any advice about this medication?
Mr. Robert, actually, after this
so
medication,
that I can be careful.
Yes, Mr. Robert. Mr. Robert, after this medication, usually we don't advise any jabs to the child. So at least for next 6 months, we will not advise any jab to your child. Apart from that, there is no other anything in specific to be taken. So I hope you understood what I said. So as we discussed, Mr. Robert, your child has nephrotic syndrome, as you already know, and he is on high dose of medications which can decrease his immunity. So unfortunately, during this time, he had a small contact with a child who had chicken pox, which is which can be very transmitted very fast. It is a very strong virus. But fortunately, we already isolated and we have called you back so that we can give him some medication which can help to prevent him getting from chicken pox. And we will also take some blood samples to make sure he's not suffering from chicken pox. If he is suffering, we have to give him some IV medications also. I hope you understood what I said, Mr. Robert.
Dr. Shinash, are you here?
Yeah, ma'am, I'm here.
Yeah. So your 3 minutes passed. Okay. Now the next question. Next question, father is asking, doctor, is there any advice you like to give me when I go home? Dr. Shinash? Hello?
Yes, ma'am. Oh, I think you muted. Yeah, you muted everyone. I think you got muted. Mr. Robert, once you go home, you have. I will give you some medications. If he has mild fever or headache, with the medications, you can take them. He needs to have good amount of water and fluids. And also, you have to watch for closely for any signs. If he has any high-grade fever or any onset of rash, you have to come back and report to us immediately. And we have to start him on injection medications through blood line for him if he develops any chicken pox.
Okay. Okay, doctor. Thank you, doctor. I will follow your advice.
Yes, Mr. Robert. So just to summarize, Mr. Robert, so today we discussed, as you already know, your son is having nephrotic syndrome and he is on medications which may decrease his immunity. Unfortunately, he was in contact with one of the child who has chickenpox. That is why we called you here to just discuss about prophylaxis for him. That is what we call as prophylaxis, the jab which we are giving so that he does not get the infection per se. So we will give him that. And also, we already discussed the possible side effects with the medication and what you should be careful about him. And you have to keep a close watch over him for the next 5 to 7 days. I hope you understood what I said, Mr. Robert.
Yes, yes, doctor. I understood, doctor. Thank you very much, doctor, for letting us know.
Yes, it was nice talking to you, Robert. If you have any other doubts, you can get back to me. I will be available for you anytime. And I hope a speedy recovery and I hope your son will not have any problems.
Okay, doctor. Thank you very much, doctor. Thank you, Dr. Sinaj. I'm very sorry for this disrupted network.
Okay.
But Dr. Sinaj, you did well. Okay, your confidence touched me, actually. Your confidence is very good. But Dr. Sinaj, only one advice I like to give you, that you talked very long sentences. Okay,
Yes.
2 or 3 points. You did not stop. Okay. Remember, communication to any person is a two-way thing. Okay, when you are talking to any person, you have to give pause. That he understood your point or not. You did not ask single time that Mr. Robert, you have any question? Did you understand, Mr. Robert? Or are you with me, Mr. Robert? And at one point, Mr. Robert told you, doctor, I am not getting you because you have given so many information in one line. So I will break this information like, Mr. Robert, hello, Mr. Robert. I am Dr. Sinaj, one of the registered in this hospital. Are you Jack's father, Mr. Robert? Yes, doctor, that's me. Mr. Robert can be any person. Jack's father, Simon's father, right? Are you Jack's father, Mr. Robert? Yes, doctor, that's me. Nice to meet you. This is not a apology scenario. This is not a breaking bad news. Am I right? So you can say, nice to meet you. And then you go to agenda. Mr. Robert, Jack has been admitted in our hospital with nephrotic syndrome few days back. Am I right? Yes, doctor. So when he was admitted, at that time he was he came in contact with a child who got chickenpox later on. That's why we called you today, so that we can give a medicine to Jack to prevent further damage or further infection to Jack. Are you with me, Mr. Robert? Yes, doctor, I understand, doctor. So, Mr. Robert, you have any question for me about this medicine or about this meeting? Now, this is the agenda. So you have to tell the person about the agenda first. You cannot ask Mr. Robert, how far you know about Jack's condition? You cannot ask this. Mr. Robert does not know anything. Am I right? Yes. So you have to ask that. So, Mr. Robert, how far you know about what I said, or how far you know about Jack having nephrotic syndrome with contact with chickenpox? Do you know anything about that? No, doctor, I did not know that he has come in contact with chickenpox. Okay, Mr. Robert. So now we need to give him a medicine that is called prophylactic medicine. That is not a medicine for treatment. Jack does not have chickenpox. That is called prophylactic medicine. And the name of the medicine is tablet or syrup acyclovir. Have you ever heard this name before? This is also prior knowledge. Dr. Sinaj, you did a major mistake here. You said we will give IVIG. We will give varicella zoster immunoglobulin. Am I right?
Yes, I think change the procedure change. Okay.
Yeah, that's why the father said, doctor, what is the medicine? What is the medicine name? Father said 2 times. Whenever father or mother said again same thing, remember that is a red flag. That means you are doing something mistake. Okay. Father said, doctor, what is the medicine? You said it is in the blood channel. It is actually giving like immunoglobulin type, varicella zoster immunoglobulin. But the point is, Dr. Sinaj, we do not give varicella zoster immunoglobulin. That this is obsolete in 2019.
No, okay.
Imanuddin Ahmed, your mic is continuously open. Okay, Dr. Iman. So, whenever you are giving information about some drug, some medicine. Dr. Shinash, very careful. This is a most important information. And if you give wrong information, you will not get mark here. So you gave a wrong information that we will give varicella zoster immunoglobulin, but actually we will give acyclovir oral from day 7 to day 14, half dose. We will not give full dose. This is for the child of immunosuppressive child. And this guideline came in 2019. Later on, this guideline is revised in 2021. So there is two guidelines actually, 2019 guideline and 2021 guideline about varicella zoster exposure to nephrotic syndrome or any immunocompromised child. So this is the two mistake, Dr. Shinash. Otherwise, your information giving was good. Your confidence was good. You talked in a very sympathetic way. We are really sorry for that. Whatever you are going through, you said that. And then you asked any concern you have, and then you offered leaflet, you offered support. Okay, you said that we will do some investigation to know Jack's condition. Yes, we will do varicella zoster status. We will do varicella zoster immunoglobulin, VZIG status. And also, before giving acyclovir, we will check liver function test. We will check full blood count because acyclovir can cause hepatotoxicity, nephrotoxicity. Okay, so before giving acyclovir, we will do some basic investigation. Father asked you, doctor, will you do some investigation to my child? Yes, we will do some basic investigation. That is complete full blood count. We will do some liver function test. We will do some kidney function test. Father will not understand you everything, but you have to say that we will do some function test like liver test, kidney test, blood test. Okay.
Yes, ma'am.
And afterwards, what is the advice? Plenty of water. You did wrong advice because you thought it is varicella zoster immunoglobulin, but actually it is acyclovir. So what advice you will give for acyclovir? You will give plenty of water. Acyclovir can cause rash, hepatotoxicity, photosensitivity. So immediately come back to us. When your child has vision problem, yellow coloration of the body, yellow coloration of the P is reduced, nephrotoxicity, P is reduced, blurring of vision, and the child has rash, please come back to us. Okay, if you give plenty of water, then the rash is minimum. Acyclovir rash is minimum if you give plenty of water. So this is the advice you will give to the father. And leaflet website about nephrotic syndrome, exposure in chickenpox. You guys only say, I will give leaflet, I will give a website. But actually, you should answer like, I will give leaflet about nephrotic syndrome child exposed in chickenpox. What leaflet you will give? Why don't you say what leaflet you will give? Am I right, Dr. Shinash?
Yes, ma'am.
Yes. So the name of the leaflet, name of the website you will give. This is and lastly, you said, I wish speedy recovery, very good line. And thank you for coming, very good line. So Dr. Shinash, there is a mild improvement you need. 95% you did, but there is still chance of 5% improvement. Am I right?
Yes, ma'am. A lot of improvement.
So now you understood that varicella, we don't give VZIG, we give acyclovir. Okay?
Yes, ma'am.
We can give plenty of water. You are right. It is a nephrotic child. Nephrotic child does not eat plenty of water, but this child is improved. That's why we discharge. No? When the nephrotic child improved and you discharged, will you tell the mother to restrict the water? Will you tell? No.
No.
You will not tell the restriction. The restriction of water only when the child is admitted because he has edema. When the child subsides edema, has a lot of urine, then we discharge. No? So after discharge, you can give plenty of water. Plenty of water does not mean gallon and gallon. Plenty of water means adequate water. You are not making your child dehydrated, right? And Dr. Shraddha is saying nephrotic syndrome, we give prophylaxis visit. No, Dr. Shraddha, the guideline is changed. And by the way, this change is not in the Green Book Pediatric Guideline. In the Green Book Pediatric Guideline, still it is written VZIG. But if you type varicella zoster guideline in the NHS, you will find that this is changed in 2019. That now every immunocompromised child, we give half dose acyclovir. We do not give varicella zoster immunoglobulin. Please go to the guideline, okay? Okay, please go to the guideline, varicella zoster immunoglobulin. Now it is changed. By the way,
Ma'am, and I have this 22, 24 guideline. Still, it's written in this that the varicella immunoglobulin is the prophylaxis and the acyclovir is the
I know, my
sign.
dear. I know, my dear. That's why we did this scenario. Just if you are in my group, who is not in my group here? Mrcpch clinical with Tamanna. Who is not in my group here? Those who are not in my group, please message me in the WhatsApp. This is my number. This is my number. Okay. Tonight, I will post the varicella guideline in my group. Varicella guideline is being changed. Okay. Varicella guideline has been changed. And now the varicella guideline says in immunocompromised child, you do not need to give varicella zoster immunoglobulin. Yes, Dr. Hira, the scenario is very clear. Okay. The child is exposed. The child did not develop rash. So in case of exposed, you have to give half dose of acyclovir. No, you can't ask the examiner the clarification. This scenario came in my exam and I got 8 out of 8 because I said acyclovir half dose. This scenario came in 2022 Nepal exam. This was my exam case. So you can't deny whatever I said. Am I right, Dr. Hira? This is my case. Dr. Shraddha, Dr. Sudha, Dr. Kumar, Dr.
Yes,
Shraddha.
you are right.
Yes.
But to me, it was a bit confusing.
Yes.
Hmm.
So Dr.
Really
Hira,
tough.
you are in my DCH group, isn't it? So
Yeah,
you
I
know
am.
the
I'm
guideline.
Mrcpch.
Yeah, so you know this guideline. I posted in the
Yes.
group.
Yes, yes.
Yes. So this guideline came actually in 2022 exam that varicella zoster immunoglobulin only given for neonate ±7. Okay.
Okay.
Okay, so the scenario is very clear. If you say this is the same line, same sentence, because this was my question. So I gave you my question. Okay, this was my exam cases. So this is the scenario. This is the scenario for Dr. Shinash. The name may be different. I can't recall the name. Half dose of acyclovir means you will give half dose of acyclovir, that is 20 milligram per kg, that is the full dose. So any child who has immunodeficiency like nephrotic syndrome, you should give half dose, that is 10 milligram per kg. Half dose from day 7 of exposure. This child has been exposed when he was admitted. Now this child is discharged. So father is called in the hospital so that they can give half dose of acyclovir to the child. We will not admit the child. We'll just take some blood sample for liver function test, kidney function test, and then we will give the acyclovir and discharge. We will not keep the child admitted. Okay. Okay.
Ma'am, just one small, just for the scenario. Like now here, we take it for granted that he acquired chickenpox from hospital because he is upset.
He's upset because you called him again. He is in hospital. He is in duty. He is in office. Think about the father. This father gone to office, okay, and you called from the hospital that there is an emergency. Please come back to hospital. How will you feel, Dr. Shinash? How will you feel?
Yeah. Yes, ma'am. Correct.
Today you could not give mock at morning. Now you are giving mock because you are not free, right?
Yes, ma'am. It's correct.
So the father is not free as well. Father has office, right?
Yeah.
So he's upset. He's upset because you called him emergency, right?
Yes, ma'am.
Okay. Anyone has any question? So
how long we are going to give acyclovir, Dr. Tamanna?
From day 7 to day 14, 7 day, half dose. Okay, I have posted this leaflet in every of my group. If you are in any of my group, you will get the guideline. Okay. And if you are not in my any group, then please WhatsApp me. This is my number. Okay, I will add you in any of my group. I have plenty of groups. I have made disabled for notification because people are crazy. They are like doing crazy in the group. Okay. So that's why I put off notification. You can call me, message me, then I will add you to the group. Okay. If you are not in the group, any group, all the groups are same notification. Okay. Okay. Now, Dr. Shinash, this is your second case clinic. Your second case is history taking, right? Okay. So I have a history that is not present in Khidir book so that you can understand that the books which are old, very, very old, the history are new. There are new history coming in exam, okay? So this is Dr. Shinar's history, a child of 5-year-old girl whose name is Salim. Salim is a 5-year-old girl who has vulval rash. Okay, Dr. Shinash? You have 2-minute time. Are you here, doctor?
Yes, ma'am. Yes, I'm here, ma'am. I'll just take down.
Yeah, yeah. Just make the DD, make the 3 column. Okay, then we will start.
Madam, should I start?
Yes, yes. Start, yes.
Vulval rash.
Yeah.
Okay. Hi, name Amina, Mother, and Salim. Okay. Hello, Miss Amina. I am Dr. Shinas. I am. How are you doing?
Yes, doctor. I'm fine, doctor. Thank you.
I am just here to ask you some things about Salim for her illness today. Can you just elaborate something? What is the main concern for which you are coming to hospital?
Doctor, my child has some rash in the private part. That's why
Okay. Okay. Can you tell me something more about the rash?
Doctor, rash is in the private part and it is sometimes itching and it is extends to the, the back passage area as well. And it's been long time, like it has been, I think 6-7 months now. And the rash is not going, doctor. I used some cream. My GP advised some cream. I used, but the rash is not going, doctor.
Okay. Is the rash increasing in or just in the same area, or is it increasing to other parts?
Yeah, doctor, the rash is also increasing. Yeah, it is not decreasing, doctor. It's increasing.
Okay, so it is only since past 6 months. Before that, Salim was fine.
Yeah, doctor. She was fine, doctor.
Okay, this part is only in the private parts. No other. The rash is not extending to the limb or to the upper body. Nothing. It is only in the private parts.
Private part and the back passage area.
Back passage area. Okay. Is there any other complaint with this, with the rash, or only rash for Salim?
She is not so well, doctor. She is very ill looking. She has some growth failure. That is also problem.
Did you measure her height anytime? I mean, did you measure her height and weight anytime?
Yes, doctor, I measured her height and weight, and it was GP said it is not good. It is below 3 something, 3 percentile or something.
Okay. And what about, did he comment anything about the weight also?
His weight, doctor, I think it was 10 kg, 10 kg, and it is very, very below the 3 centile, doctor.
Okay. Apart from this rash here, does she have any other complaints which you are worried about? Rash and the growth, the failure to grow. Is there any other complaint which you are worried about?
No, doctor.
Okay. Does she have any fever? Did she have any recurrent fever or any fever during this past 6 months?
She has on and off fever. Yes, you are right, but not continuous. Like 1 or 2 days, she has fever like that.
Okay. For this fever, do you take any antibiotics, or the fever is subsided by itself?
Subsided by itself. No antibiotic given.
Okay. Does she have any pain in the joint area or any pain anywhere?
No, doctor.
Does she have any diarrhea with this? Is she having loose stool?
Sometime, yeah, doctor. Sometimes she has diarrhea as well.
Is this, can you just tell me something more about the diarrhea? Is it like very frequent, or?
The diarrhea is, doctor, on and off. On and off,
Okay.
like sometimes there is diarrhea, sometimes not.
Okay, so it is not every day.
No, doctor.
Okay, so does she have any, so in between constipation or anything with that?
Yeah, sometimes she has constipation, doctor. Sometimes she has diarrhea.
Okay. Did she have? Does she have? Is she on diapers, or still have you? She's already toilet trained.
She's on diaper, doctor.
Okay, she's on diaper. So are you changing the diaper very frequently in the night also?
I change sometime, doctor. Sometime
Okay.
I forget I slept.
Okay. This does she? She's, so that means she's still passing urine in the night when you open the diaper.
Yeah, doctor. I can't break my sleep. You know, I have migraine, so I can't break my sleep. So I put diaper on her whole night.
Oh, I understand, ma'am. It must be difficult for you with this migraine. Always, you must be having headache if you break your sleep. It's okay. Is she taken care by only you, or is there anybody else who's taking care of her?
Doctor, I work 5 days, so there is a nanny, part-time nanny, and she goes to nursery as well. She goes to nursery, and then her nanny is there.
Okay. This nanny is there from long time. She is there with her from long time.
This nanny is from, yeah, doctor, I think last 2 or 3 years, this nanny with her.
Okay. Anytime when she passed a stool or anytime in the anal area, have you seen any small whitish like a worm or anything?
A worm, I did not notice, doctor, sorry.
Okay, that's okay, ma'am. Okay, does she have any previous any illness in the past?
She has on and off fever and diarrhea. Otherwise, she's fussy, doctor. She's very fussy eater. She doesn't like any particular type of food. She eats very little.
Okay. Has she been admitted, or is she following any team in anywhere, any hospital?
No, doctor, just GP.
Okay. And did she have any previous history of urine infection, or did she undergo any surgery or anything in the past?
No surgery, but yeah, there was 1 or 2 times P infection, and GP gave some oral medicine, and she recovered.
Okay. There was no jelly scan, anything done for this P infection? After P infection, was there any jelly scan done?
No, doctor.
Okay. Her before birth, after birth, and during birth, did she have any other problems?
When she was in home, she has, I think, I used to take alcohol.
Okay.
So 1 or 2 times I felt less fetal movement. So I got admitted in hospital, but then doctor discharged me. Doctor said nothing problem.
Okay. So after delivery, she did not have any special, any difference to her face or body. Doctor did not tell anything like that.
No, doctor, no, we discharged.
Okay. Developmental wise, how is she doing? She's developmentally doing fine, like other children of her age, because she's already going to the, you said nursery.
What do you mean by development, doctor?
Now she's 5 years. She is playing with other children of her age. She's sharing a toy. Is she going up and down?
She does not like to share toy. And she up and down, no, she's still very struggling to up and down. She just started walking at 3 years, doctor. At 3 years, she could start walk, but at 2 years, she could stand. And I think she's very behind.
Okay. And she's able to go up the stairs?
Now she can with holding the railing.
Okay. Does she go up the stairs with two step? The both the legs are the same step, or she can go one by one?
One leg, but she holds the railing.
Okay. Can she come down also?
Yeah, same manner she comes down. Yeah.
She can come down. And if she play with blocks and toys when she's at home?
Yeah, doctor. She plays, doctor.
Okay, so she can make like a tower. If you give around 5 or 8 blocks, can she make a tower with them?
She can make, yeah.
Okay, she can make a tower of around 9 blocks, is it?
I will say I did not count actually, but maybe, yeah, 8, 9, maybe.
Okay. And what about her language? Does she recite any story to you anytime?
No, this is my another concern. She speaks very little, doctor. She speaks like mom, mom. So she doesn't have any sentences. She just say word like water, words. She doesn't make sentences as well.
Okay. So do you speak English at home, or you have like any other language which you speak at home?
No, we English. We are British, doctor.
Okay. So she can join 2 words if she requires anything like water. Does she tell mom water?
No, doctor. Only one word.
Okay, only one word. Okay.
9 minutes, Dr. Shinash? 9 minutes.
9 minutes. Okay. Thank you. Thank you,
No. You have 4 minutes left. 13 minutes total.
Sorry. Yes, ma'am. Sorry. We finished. Language. Okay. Drugs. Is she taking any medications?
No, doctor. Only 1 or 2 times GP gave antibiotic and or saline for diarrhea. That's it.
Okay. What about her jabs? Has she received all the jabs?
I went 2, 3 times in GP. I don't know actually. She received all the jabs. I did not count actually.
Okay. What about her? Any family? Is there any family history of any similar illness or other children in a family are fine?
Doctor, no, I am not living with my mom. When I was 16, I came out of home. Then I had a partner with whom my daughter born, Salim.
Okay.
And then we separated. And now I live with my another boyfriend. So I have no family, doctor. I don't know. I don't know my previous partner as well. I don't know my recent partner as well.
Okay. So you are not related to your first partner also. So
No,
how are you managing? How are you managing with your expenses? I know it must be difficult with her condition. She's having this growth failure and problems. So how are you managing?
Yeah, doctor, you are. Thank you very much for understanding, doctor. Yeah, I am very much struggling, doctor, with 5 days work and childcare cost. You know how much cost it is.
So are you getting any support for this?
No, doctor, I never got any support from anyone.
Okay, and just to clarify one more thing, we will try to we will try to help you out with this. I will try to for your daily allowance. I think she will deserve for that, so we will try to help you out with that. But I just wanted to know one more thing. Your new partner, how is he towards? He's playful with her, or how is he towards Celine?
No, doctor, don't ask this question. This is a war in my home. My new partner, when he comes, he screams at my daughter. My daughter cries. Oh, it's a mess, doctor. It's a mess. Don't
Oh,
ask
I'm
me
so
this.
sorry. Very sorry to hear about that, Miss Amina. I'm really sorry. The situation is not good at your house. Uh, I hope we can help you with this also. Does in school does she have any other issues or bullying at school? You think because she's going to nursery, she is having any caretaker issues with the school?
I think, doctor, because she is not bullied, but I think they are not taking care of my child because she doesn't want to go to nursery. She cries all the time, doctor. She's very clingy. She's very less weight. She cries all the time. I don't know what to do, doctor. Please help me. I don't know, doctor, what to do.
Yes, don't worry, Ms. Amina. We can help you out. We will help. We will refer you to the appropriate specialities. They will help you out with all these issues. So, is there anything else you want to tell me, which we might have missed?
I just want to make her good, doctor. I'm a mom. You can think how much worried I am for her. So just do good, doctor, please.
Yes, I really understand your concern for your daughter, and I think she really needs support also. We will try to help her out with anything. That is why I just wanted to know if you want to tell me anything which we must have missed, so that I don't miss anything to help her. Anyways, thank you very much, Miss Amina, for giving us the time and giving us all this information about Salim. We will discuss with the appropriate this, and we will formulate a plan for you.
Thank you, doctor.
Thank you so much.
What is the last line?
We wish Salim a good life, and she will get over this issue very fast. And we wish her a
Okay.
speedy recovery.
Thank you. Thank you, doctor. Very good. Well done, Dr. Shinash. So present your case. Present your case.
This is today I happen to speak to Amina. She is mother of a 5-year-old Salim, who is concerned for her daughter's vulval rash, which is there since 6 months of age, with no significant. She also has history of recurrent infections with no clear cause. She also has previous 2 UTIs, urinary tract infection, which has been treated, but no further investigation done. She also seems to be having delayed growth as she falls well below less than third centile for height and weight. She is also having a developmental delay, which involves both gross motor as well as speech delay. So she's having a global developmental delay. The mom Amina, she's her present partner. He's not well with Salim, and she is struggling to meet ends meet, and she needs support for the same. So my differential diagnosis for this patient, it can be the rash. She can have vulvovaginitis with this, and with this recurrent fever and recurrent, she may have some immunodeficiency. It may be a fungal rash. She may be also having nocturnal enuresis, which due to which a mother is not changing frequently diapers, so she is having this rash as contact dermatitis. We cannot rule out sexual abuse also for her with this history of the surrounding at home and school.
So, what is your diagnosis?
First is probably vulvovaginitis with recurrent infection, maybe immunodeficiency. Second is contact dermatitis, secondary to nocturnal enuresis. But the developmental delay will not be explained by this. Third is sexual abuse with child neglect, because she is having developmental delay also. Fourth is nocturnal enuresis with diaper rash. Fifth is cerebral palsy. Before that, one cerebral. Yes, ma'am.
You said nocturnal enuresis with diaper rash.
Cerebral palsy also. She had. Sorry, I should have told that earlier. Cerebral palsy, because mother has maybe child is also having fetal alcohol syndrome because she's having developmental delay, and with this cerebral palsy, she's having child neglect, which is leading to this rashes.
Okay. How will you investigate this child?
I will involve my senior also, and I will involve the multidisciplinary team involving as community pediatrician being the central, playing the central role. She so she will need initially full blood counts to rule out infections. She will be need to do her electrolytes because she is having like sodium, potassium, calcium because she is having failure to thrive. We will also do some investigations like stool examination to rule out any to rule out any worm infestations. We will do her urine examination and urine analysis to rule out urinary tract infection because she has previous history of urinary tract infection. For her developmental delay, we will also rule. We need to do CT brain or MRI brain to rule out the cause for her developmental delay. After this, the multidisciplinary we will involve a developmental pediatrician to do her delay. We need to do her a complete developmental assessment for her as she's having developmental delay. She has a history of query fetal alcohol syndrome, so we will do an echo for her also to rule out any cardiac issues. And
how will you manage this patient?
Yes, we will involve multidisciplinary team involving as community pediatrician as central role. We will refer the child to dietitian nutrition for her nutrition. We will refer the child to developmental pediatrician to do a detailed developmental assessment. We will refer the child to, we will involve the social services also with suspicion of child abuse and child neglect. We will involve she did not give any history of seizures. If there is seizure, we will involve a child, a neurologist also.
No. That's history you got. Only tell me about those. The history you got. The history you did not get, tell me. Yeah.
Okay, ma'am. Okay. So social, this one, pediatrician, developmental pediatrician, and community support, and also we will the school, we will involve the social worker for school also to see her school environment.
Okay. Any drug treatment needed for this child? Any medicine treatment needed?
After investigations for this vulvogenitis, if it is she needs we need to educate the mother regarding the change of diapers and wearing loose clothes. Because this may be a vulvogenitis which is coming recurrently with as a contact because of the contact. Also, we can use antibiotic creams and mild steroids for the acute infection, and to prevent the infection, we have to educate the mother regarding the frequent change of diapers and try to make the child toilet trained so that she can remove the diapers. And we have to, for the development, we have to give her more stimulation, and we have to do hearing tests and other tests to see further delay because she has significant speech delay.
Okay. Okay. What advice you will give, Dr. Shinash, to the child, ma'am, to the child mother? What advice? What advice, Dr. Shinash? Hello.
Sorry, ma'am, it became mute. Yeah, we have to tell her regarding the hygiene, the oral hygiene. The local hygiene of the area. She has to do. She should not use very hot water, or she should not use very strong soaps in that area. She should use light clothes. She should have frequent change of diapers, and she should keep the area dry. And after further assessment with for the house, this one, she has to talk to the she has to be more careful for her child because she may be undergoing some sort of child abuse and child neglect. So she has to be we'll ask her to be more vigilant and more careful.
Okay. Thank you, Dr. Shinash. Well done.
Thank you.
Okay, there will be three more question, like question about your DD. They will ask you, why do you think it is sepsis? Why do you think this is vulvovaginitis? Why do you think this is immunodeficiency? Okay, there'll be 2 or 3 more question more, but as due
Yes,
to limited time, we can't go that detail. So
Yes,
Dr.
ma'am.
Shinash, first of all, I congratulate you. Well done. 13-minute history, 9-minute question answer. This is too long, lengthy time, and you overcome this time. So well done. Okay, and you did good. Your DDs are very good. I like your DD, but the history taking, you missed some point. So when you start onset course duration, right? So in history taking, what we will do, we will follow our protocol, that is 3-column approach. When you enter into the room, remember, you have to follow the DD, at least 5 to 7 DD for every case in Mrcpch. And in DCH, at least 3 to 5 DD. Then you will make a 3-column approach. Okay. In the first column, we ask history of present illness and we ask systemic inquiry. In the second column, we ask history of past illness and we ask about others. In the third column, we ask about social history. Dr. Shinash actually followed this column. So he was not too haphazard. He was good. His structure was good. Okay. So Dr. Shinash, in the history of present illness, onset, course, duration, you asked about any other system, very good. You asked about systemic inquiry, but in the systemic inquiry, you missed some point, okay? You missed that in the skill survey. You asked that, is there any other area rash? Mother only said no, in the vulva, vagina and anal area, right? You asked about growth. You did not ask about rash in the mouth, inside mouth. One of the DD in this child is Dr. Shinash, IBD, celiac disease. Am I right or wrong?
Yes, ma'am.
One of the DD, IBD, celiac disease, you did not mention. So rash, oral rash, thrush, oral thrush. Oral thrush is not a rash. Mother did not tell you. This child had oral rash. Because in immunodeficiency, there is oral rash and perianal ulcer. Perineal valval ulcer, right? So
Yes, ma'am.
you did not ask about oral rash. You did not ask about pallor, racing heartbeat. This child is pale, Dr. Shinash. His failure to thrive. He has racing heartbeat. You did not complete your immunodeficiency. You did not complete your systemic inquiry. Am I right? Pallor, racing. Think about head to toe. You did not ask about healing change. This child can be kwashiorkor. Am I right? This child can be protein energy malnutrition. So you did not ask about sign symptom of kwashiorkor. Is there any hearing loss? Hair change? Is there any mood change? Irritable cry? The mother said you, doctor, he's crying all the time, screaming and crying. So this can be irritable child. Am I right? So this can be a kwashiorkor child. Okay. We are only concentrating on the vulvar rash. We have to concentrate on the full child. Okay. So you did not ask about sign symptom of kwashiorkor. You did not ask about pallor. You did not ask about racing heartbeat, any fit. Okay. Then any breathing problem, any repeated chest infection, bug infection, okay, any bowing of the limb, ricket. This child can have ricket. Any malnourished child can have ricket. Am I right? Any abnormal movement, that is called calcium deficiency, tremor, fit. This child has or no? So systemic inquiry was incomplete, Dr. Shinash. You had time. You asked 2-3 questions same time. 2-3 questions. You asked multiple time about drug history. You asked multiple time about I think school history. 1 or 2 history you asked multiple time. I can't remember now. When I see the recording, I will know. So 2-3 things you asked multiple time, but you did not ask about, in the history of past illness, you asked about perinatal history, very good. There was features of fetal alcohol, but doctor discharge actually. So the child was not in fetal alcohol syndrome, doctor discharge. So the child had immunodeficiency. You did not ask about birth weight, Dr. Shinash. Birth weight is very important here. The child was preterm. You did not ask about term. Okay. Only you listen fetal alcohol and you jump to the other system. Am I right? You did not complete birth history. That what was the birth weight? What was the birth? I mean, is it term or preterm? Okay. Mother told you this is normal delivery. He cried immediately. We discharged, but you did not know what is the age of the child. What is the weight of the child? Then you did not ask about feeding, Dr. Shinash. Very, very bad. You did not ask anything about feeding. And when, how much breastfeeding he took. Can you describe me his daily feed? What he took, calorie? If in the protein energy malnutrition child, If in the failure to thrive child, you do not ask feeding diary, feeding 24-hour, what the child is eating, then you will get a very low mark because this child is failure to thrive. Mother told you he does not eat anything, doctor. He screams, he cries because he is malnourished. So you have to tell about his daily routine, that what he eats from morning to night. Can you tell me, mom? This is called food diary. Mom will tell you he eats at breakfast, he eats at lunch, this. This mom is a stupid mother. Am I right? This is a stupid mom. She does not know her baby is vaccinated or not. So this is a stupid mom. She does not change the diaper at night. So this is a very stupid mom. So you have to dig out what she eat at lunch, what she eat at dinner. Then you have to say, any traveling, you did not ask. How you ask immunization? You ask jab, right? Jab or shot.
Yes, ma'am.
You asked that. Mom could not answer. So this is a case of neglect, clear neglect. In your DD, you said sexual abuse. But did you say neglect?
Yeah.
Did you say neglect or you said only sexual abuse?
No, ma'am, I just said neglect.
Okay. If you said neglect, then it is okay. This child is a clear-cut case of neglect. Okay. And sexual abuse also, because the partner, whose mom's partner is coming to home, staying at night. In the systemic, in the second column, you did not ask about traveling history. Why traveling history is important? Giardiasis. Okay. Giardiasis, chronic diarrhea. Chronic diarrhea can cause failure to thrive. Okay. Feeding history, you did not ask. You were too concentrated on the development, Dr. Shinash. This is not a developmental station. This is a history station. So you should not concentrate so much. You just say the mother, when was the talking? When walking? Mother said it is delayed. How much delay? Doctor, at 2 years, he started walking. At 3 years, he started going upstairs and downstairs. And at 2 years, he could start mama. And at 3 years, just he said word. This is enough. Building how many block? No need. He can use cup or spoon. No, doctor, he can use cup, but not spoon. Enough. Enough. Because this child is global developmental delay because of failure to thrive, because of neglect, or because of sexual abuse, or because of protein allergy malnutrition, or because of giardiasis. But this global delay with failure to thrive, this is common. And vulval rash is just a manifestation for last 6 months. This vulval rash can be anything. It can be UTI, it can be infection, vulvovaginitis. It can be, you did not ask how you wipe the private area. Mother would say from back to front. But is it the appropriate, correct idea? Idea is from front to back. Right? So this mother did not tell you he is doing wrong, she is doing wrong. So this is the Dr. Shinash, that this child has multiple problems because family is broken. Mother is alone, doing job, the child is in nanny, and the partner is coming, new partner, right? In the social history, you try to explore, but you did not explore how many bedroom. The child sleeps alone or sleep with you. How many bedroom? Is there any pet? Why pet? Some allergy can transmit from pet, right? Is there any, are you getting any DLA? You said that. Are you getting any social support? You said that, you asked that. So social history, how about nursery? You asked that. How about sleep? Does he wake up from sleep and cry at sleep? Doctor, I don't know. I did not notice because she lives in her own room. She sleeps on her own room. Maybe she cried 1 or 2 times. So sleep is very important, okay? And itchy, is she itchy? Mother said yes, this is itchy, there is some blood spot, so it can be helminthic infestation, right? Threadworm infestation.
Yes.
So this is all the DD, threadworm, UTI, incorrect technique, vulvovaginitis, contact dermatitis, because the child did not. This child can have zinc deficiency, acrodermatitis enteropathica. This child can have celiac disease. This child can have IBD. There are very, very wide DD for this child. IBD has rash, perianal rash, isn't it? Celiac has rash. Zinc, acrodermatitis enteropathica has rash. Vulval rash or perianal rash. Am I right? So this child is failure to thrive with vulval rash, with neglect, with global developmental delay. Now the DDs are long list for this child. Okay. So this is your history taking, 13 minutes. Now, when I said, what is the management of this child? You asked from investigation, but whenever I say management, you have to say, I will take full history from the mother. I will do detailed physical examination. I will do developmental assessment, and then I will admit this child. What is the need of this admission? He is failure to thrive. See, 10 kg, 5-year-old 10 kg, he is below third centile. This is a red flag. Okay, so you have to admit this child. Lactose intolerance, someone said, I would not agree, because lactose primary, there are two kinds of lactose intolerance, okay, primary and secondary. Secondary lactose intolerance after diarrhea, okay, this child had diarrhea. And secondary lactose intolerance, one of the DD is celiac disease, cystic fibrosis, and IBD, okay. Primary lactose intolerance is very rare, 1 in 1 lakh. So don't say lactose intolerance, say chronic diarrhea. The causes of chronic diarrhea is IBD, celiac disease, giardiasis, okay, immunodeficiency. These are the causes of chronic diarrhea, and acrodermatitis enteropathica. These are the causes of chronic diarrhea. Lactose intolerance, 1 in 1 lakh. So very, very rare. I would not go in that way, okay? And you have to involve the multidisciplinary team. Consultant pediatrician is involved. Developmental pediatrician is involved. Then many doctors will be involved. Genetist will involve, immunologist will involve this, because this child can be immunodeficiency. Social service will be involved. You are right. And in that management, Dr. Shinash, you have to manage this in how many categories, Dr. Shinash? 1 category is immediate management.
Yes.
2 category is late after stabilized management. And 3 category is discharge management. Am I right, Dr. Shinash? So immediate management is, I will do immediate investigation, complete blood count, see the hemoglobin. If the child hemoglobin is 6 or below, sign symptom of heart failure, I will do blood transfusion, or I will give iron hematinics. This is the first line investigation, okay? First line management. I will stabilize the child, airway, breathing, circulation, everything. Then bleeding, then anemia, okay? Then I'll involve the multidisciplinary team, I'll involve social service for the cause of this delay, okay? And then late management is according, I will give appropriate nutrition. So dietitian will be involved. I will calculate the calorie and then give slowly calculated calorie. You cannot give fast calorie. You have to give slow calorie, right? Yes. According to the malnutrition formula, I will give the calorie. And then I will give antibiotic. I will give pseudo cream in the vaginal area, zinc cream, pseudo cream, okay? According to the cause, I will manage the child. If there is zinc deficiency, I will give high dose oral zinc. If there is giardiasis, I will give albendazole. If there is threadworm, I will give mebendazole. Okay. If there is celiac disease, I will introduce gluten-free formula. If there is IBD, I'll involve the gastroenterologist and I will start elemental diet or steroid. This is the management drug portion. This is called late management. Then during discharge management, after doing all this management drug and everything, when you discharge, I will give advice to the mother about safe child care. Safe child care. And then I will give advice how to make a hygiene from front to back, not from back to front. I will cut the nail of the child and the mother so that that is not injured. Okay. I will give developmental stimulation. So I'll refer this child to the developmental pediatrician for stimulation, dietitian for proper nutrition, and parent education. Okay. Then I will give at night loose cloth, no diaper at night, pseudo cream, and repeated change of the clothing of P clothing. And I will prevent constipation. For diarrhea, I will treat appropriate method so that there is no diarrhea. If there is threadworm, pinworm, I will advise family support for threadworm or pinworm. Family will be eradicated. And I will wash all the clothes into the hot water if there is any worm infestation. Okay. I will not use any antiseptic solution and antiseptic cream in the area, but we can use vinegar, half vinegar and half water. We can use for soothing the area. Okay, Dr. Shinash, and yes, I will refer this patient to the GP for proper vaccination. Mother said, I don't know. So in the advice, you have to refer this child to the GP for proper vaccination. Am I right?
Yes.
Okay. And investigation, you have to say why you are doing this investigation. Investigation for diagnosis, investigation for complication, investigation for management, and investigation for baseline investigation. Investigation for diagnosis according to the differential diagnosis. Okay. So
Yes, ma'am.
this is your history. So many things to improve, inshallah, but your idea is clear, very clear. But you need to read more topics. What are the DD of this, okay?
Yes, ma'am.
Okay.
Ma'am, just one
All
thing
the
now,
best.
for example, just one last question, ma'am. Just because this one, like, for example, we got the history of developmental delay at the end. So can we go back, like, to ask history, like, is there any seizure or anything like that? Or shall we continue like that only?
You can. When you know, at any point, you know, mother is telling you new history. He's giving you new information. You can go back. There is no harm. You can just say, Mom, I forgot to ask you, or I missed some point that, do you have any abnormal movement? Do you have any bowing of the leg? Do you have any oral thrush? You can go back anytime.
Okay, ma'am.
This
Okay,
child
thank you.
neglect on top. This child neglect is not on the top. He did not say neglect on the top. He said failure to thrive with malnutrition, with global developmental delay. Probably there is vulvovaginitis. This is doctor first answer was vulvovaginitis, then was immunodeficiency. Number 3, he said neglect. Number 4, he said sexual abuse. Yeah, neglect never should be first. It should be like 2 or 3 number. Yes. Okay, Dr. Bella, are you ready? Anyone has any question about this scenario?
Yes, Dr. Tamana, I have this differential diagnosis that this is, I think, on the basis of the history, this is the problem list that this baby have vulvovaginous clear cut with failure to thrive, global development delay, and child neglect that we got from the history. But for the differential
This
diagnosis,
is the diagnosis, doctor. This child has failure to thrive with global developmental delay, with vulvovaginitis.
Yeah. So the failure to thrive is not a diagnosis. It is we have what is the reason for failure to thrive, or what is the cause for global developmental delay? Like at the
There
end,
is a
we
chapter
added the
in Green Book
underlying
of
cause could
Pediatrics,
be
failure to thrive.
immunodeficiency.
Failure to thrive is a diagnosis, doctor.
But there should be underlying cause for it, like immunodeficiency, or as you discussed, the celiac disease or IBD.
You are not letting. Yeah, you are not letting me finish, Dr. Kumar. What doctor said, Dr. Shina said, this is a child of failure to thrive with global developmental delay, with vulvovaginitis, probably due to 1, 2, 3, 4, 5, 6, 7. These 7 causes are the cause of global developmental delay with failure to thrive with vulvovaginitis. Am I clear to you now?
Yeah, that's what I said.
I hope so. Okay. Yes, that's what Dr. Shinash also said. He did not say only failure to thrive. He said multiple things. He said failure to thrive with global developmental delay, with vulvovaginitis, 1, 2, 3, 4, 5, 6, 7. He said 7 differential diagnoses. Okay, he only did mistake. He did not bring celiac disease. He did not bring IBD. Okay, he did not bring acrodermatitis enteropathica. He did not bring giardiasis. This thing only he missed. Otherwise, it was okay. His differential is okay. Okay, Dr. Kumar?
Yes, but with this celiac disease, there is no clear-cut history of the IBD, the diarrhea. There's a mixed history of the diarrhea, and could be a nutritional problem, the feeding issue. The history is vulvovaginitis, not about the diarrhea, the chronic diarrhea, that we include the celiac or the IBD. It could be we should rule out, but
there was diarrhea alternating with constipation, so celiac should be there.
So you want to give only 2 or 3 differential diagnoses. Okay, no problem. But my advice in my course, I teach everyone to give at least 5 to 7 differential diagnoses so that the examiner know your basic. Okay. If you like to give only 2 or 3 differential, it's okay. You can give. Everybody has different choices, right? There is no clear-cut formula for passing the clinical exam. If you want to give only 2 or 3 fixed differential, it's okay. You can give. But for me, I like every differential diagnosis that is possible for this child. There is anemia. He did not ask about abdominal distension. There was abdominal distension. There is intermittent diarrhea and failure to thrive and rash. So why not? It can be a case of celiac disease. Am I right? Okay, now Dr. Bella, this is
Yes,
your
I'm ready.
clinical. Yes, Dr. Bella, this is your clinical station. Wait, I'm giving you a clinical scenario. Dr. Bella, which system you like?
CVS.
CVS? Okay, well done.
What?
Yes, Dr. Bella, this is your child. Her name is Nina.
Age. Age, Dr. Tamanna, her age is?
Dr. Bella, you ready?
Yes. Age of the child, Dr. Tamanna?
5 year. Her name is Nina.
Okay. So
Okay, start.
I'm going to verbalize and you're giving me the data.
Giving my data, yes. And suppose this is the child in front of you. You are giving online, offline exam. So the child will be there.
Okay, so I'm going to start with the building up some repo. I'm going to wash my hand, introduce and build some repo and taking for the permission. Then I'll start to do the journal impression. She is looking well, smiling. There is some coarse faces and there is a thin upper lip. She is pink and there is nothing in the surrounding. I'll start the local examination. I'll look at the hand to check for the clubbing and the cyanosis. Is there any?
There is no clubbing, no cyanosis.
Okay, then I'll look for the stigma of the infective endocarditis in the form of the Jen, lesion, nostril nodes, and the splinter hemorrhages.
Yes, there is
Then
nothing.
I'll check the pulse. What is the pulse rate? Volume of the pulse?
Volume normal. Pulse is 72 beats per
Okay,
minute.
is there any
Regular.
radio-radial delay?
No radio-radial delay.
Okay, then I will go up to check for any water hammer pulse.
There
Then
is no water hammer pulse because the volume is normal.
Okay. So I will look for the anemia and the jaundice. Is there any?
There is no anemia, no jaundice.
Okay, I'll look for the oral cavity to check for the central cyanosis, any hygiene and mucosa.
The oral hygiene is good. There is no ulcer. Okay, there is no central cyanosis, no high arch palate.
Okay, and there is no cleft palate also. Okay, so
No.
I'll look for the neck for any visible pulsation, any scar marks, any swelling.
No, no scar mark, no visible pulsation, no swelling.
Okay, then I'll start doing the local examination. First, I'll take the appropriate exposure, but to keep the dignity of the child. Then I'll do the inspection from 3 views. I'll check for any visible pulsation,
There is no visible pulsation.
any scar marks,
No scar mark.
shape of the chest, any deformity.
No deformity in the chest.
Okay, any bulge.
No bulging.
Okay, then I'll start counting the respiratory rate, and then I'll warm up my hands. I'll just explain to the girl and try to look at the apex beat with my both hands to rule out the dextrocardia, and then I'll palpate the apex beat. Is it palpable?
Apex beat is palpable in the left fifth intercostal space, just medial to the mid-clavicular line.
Okay, so what is the character of the apex beat? It is heaving or tapping?
No, normal.
Okay, then I'll palpate all 4 areas and I'll look for the left parasternal heave to check for the right ventricular hypertrophy. Is it there?
Yes, right ventricular hypertrophy is present.
Okay, then I will start doing the auscultation. I'll first palpate the carotid to differentiate the S1, S2. Then I'll auscultate the S1, S2. Is it audible and any added sound? All 4 areas.
S1, S2 is audible, lub dub, but the S2 is soft and single.
Okay, is there any added sound?
No added sound.
Okay, then I will look. Is there any clicks?
No click.
In all 4 areas. Okay, then
Yes.
I will now look at the back to check for any scar mark.
There is no scar mark in the back. You finished front, you went back. Why?
Yes.
Okay.
Then I will also check for the basal crepitations.
There is no basal crepitations.
Okay, and then I will try to palpate the spleen and edema. I'll check
No
the
spleen.
edema.
No spleen, no pedal edema.
Okay.
You
That's
finished?
all. Yes. Yes,
Minute,
finish.
1 minute still left. You would like to do anything else?
Yes, I would like to check for any swelling in the abdomen.
No, no swelling.
Okay, and
Okay, complete.
that's
Finish your
all.
case. Finish your case.
Okay, that's all I'm done.
Okay,
So,
finish. I mean, present your case. Sorry.
Today I have examined 5-year-old Nina. She is looking well. She has some coarse facial features and there is a smooth, thin upper lip. And there is no peripheral cyanosis, no clubbing. The pulse rate is 75 beats per minute. It is normal volume pulse. There is no stigma of infective endocarditis. And on local examination, the apex beat is located in the fifth intercostal space, just medial to the mid-clavicular line. It is normal, and there is a left parasternal heave. And there is a S1, S2 audible, with the S2 is soft. There is no added sound. There is no signs of congestive cardiac failure. There is no stigma of infective endocarditis. I would also like to complete my examination by just plotting her centiles and check her saturation and blood pressures.
Okay. So what is your diagnosis?
My diagnosis is it can be a case of TOF, pink TOF, and my other differential could be there is mild pulmonary stenosis, and
Okay. Is this child syndromic or non-syndromic?
this child is syndromic. So the lip shape is suggestive of Williams syndrome.
Okay. So you said TOF, right? You said pulmonary stenosis.
Yes.
Okay. How will you investigate this child now?
I'm going to perform chest X-ray to check for the cardiomegaly and the lung fields also. Then I will go for the ECG to check for the right ventricular hypertrophy, and the diagnostic will be echocardiography.
Okay. So how will you manage this patient now?
Yes, I will manage on the basis of the diagnosis. I'm going to involve the multidisciplinary, my consultant. I would also like to involve cardiologist, and also reassure the family as the child is fine. And if it is pulmonary stenosis, then I would like to check the gradient and advise exercise and some journal advice in terms of maintain the good dental hygiene, proper hand wash, avoid piercing the body, and exercise on the depends on the diagnosis of the child. And
Suppose it's a case of pulmonary stenosis. How will you manage pulmonary stenosis?
pulmonary stenosis, if it is mild, then we are going to do the wait and watch. And if it is causing symptoms, and if it is moderate and there is a gradient of more than 40 to 60 or even more than 60, then we are going to do the percutaneous balloon balloon dilatation of the pulmonary valve. If it is there can be surgical options also.
What is the indication of surgery in pulmonary stenosis?
Yes, sir. Indication when there is severe pulmonary stenosis and it is causing cyanosis. So in that case, we can perform a surgical procedure, pulmonary valvotomy. I'm not sure.
What is the indication? Number one, you said failure of balloon valvoplasty, right?
Yes, failure of balloon valvoplasty, and there is a
Okay, well done, Dr. Bella, well done. So Dr. Bella, what are the complications of Williams syndrome?
Yes, Williams syndrome, there is a hypercalcemia, and there is also immunodeficiency, and there is a aortic valve can also be involved. There is supravalvular aortic stenosis and subaortic membrane, and also it is associated with PS.
Okay, well done. Okay, more than that question will not be asked in exam. Okay, so I am very happy with Dr. Bella. At least Dr. Bella could identify this is a PS. But why you said first TOF, Dr. Bella? TOF is more common than PS, or PS is more common than TOF?
PS is more common.
Yes. So your first differential should not be TOF. Your first differential should be PS, right?
Okay.
Why did not you ask me about thrill, Dr. Bella?
Thrill, okay. Okay.
You missed thrill, right? You did not ask me about the murmur gradient. Did you ask me about the murmur at all? Ejection systolic murmur. Did you ask me?
I asked you, is there any added sound? I did not say this word murmur, but I should have said.
Yes, I did not tell
notify
you added sound. Added sound and murmur is a little different. Added sound means click, pericardial rub. Okay, murmur is different. You should ask, is there any murmur?
Okay,
You did not ask me at all. I remember because I did not tell you what is the murmur.
I did not say murmur.
Yeah.
I was wondering that there is no murmur.
Don't say murmur. If you don't say murmur, then it will not come as grading as well.
Yes.
I found in between you are lost. When I said no, that time you should clarify, is there any murmur? I said added sound. Murmur is a type of added sound, but there are more added sound like click, pericardial rub. Those I said no. Okay. Murmur, I was thinking that when you will ask me murmur, but you never asked. Okay.
Okay.
So this child can be ejection systolic murmur in the left side, pulmonary stenosis, right? You did not ask me about grading as well. Okay. And then you should give differential as innocent murmur. Okay. That is the site for innocent murmur. This child has pulmonary stenosis, peripheral pulmonary stenosis actually. So it causes right ventricular hypertrophy. There was heave present. So when there is heave present, you know this is right ventricular hypertrophy, right? That time you must ask me, is there any murmur? Because how the heave is coming now? Dr. Bella, if you think there is no murmur, how the heave is coming? From where the heave is coming?
Okay.
Okay. I found like a little bit distracted you were when you were coming to, like in the palpation part, there is heave, there is thrill. You missed thrill. You did not ask me, is there any thrill? Thrill means what? Palpable murmur. Okay.
Yes.
You asked heave, you missed thrill. If you asked me, Dr. Bella, is there any thrill? I would say yes. And then you could ask me, is there any murmur? I could say yes. Because this child has peripheral pulmonary stenosis. In Williams syndrome, most common is aortic stenosis. Second common is peripheral pulmonary stenosis. This is second common child. Okay. But Alhamdulillah, you picked the main points that there is right ventricular heave. So it can be pulmonary stenosis and it can be aortic stenosis as well. But your tough diagnosis should not come first because the child has no clubbing, no cyanosis. So tough diagnosis should not come first. Am I right? Tough means what? The child should be diagnosed within 6 months if it is tough. If it is pink tough, yes, he will diagnose later. But even then, Dr. Bella, in pink tough, there will be mild degree of cyanosis or mild degree of clubbing. May not be fully pink. And there will be right ventricular hypertrophy, ejection systolic murmur, and there will be failure to thrive. And there will be BT shunt if it is shunted child. There is no scar, so it is not BT shunt. This child can have TOF, but very rarely. This is a 5-year-old. Do you think 5-year-old without treatment, she will be alive? Pink TOF are very rare, okay? So I think you missed some point. You missed thrill, number one. You missed in the auscultation, you did not ask me specifically about murmur. You asked me any added sound, I said no. But you should ask me because there is heave present. You forget thrill. Okay, you forget palpable P2. This child has palpable P2 because there is pulmonary stenosis. So this child has palpable P2. So you did not ask me about palpable P2. Palpable P2 by 2 finger in the pulmonary area. Am I right? You did not ask.
Yes.
Palpable P2 is mainly due to valvular problem. This child may not have, but you should ask palpable P2.
Okay, I have one question, Dr. Tamanna. You told me this second heart sound is soft and single. So can you tell me the interpretation, like when we say this is single second heart sound, so what could be the DDs?
When there is single soft second heart sound, you have to understand one channel is blocked. This child has pulmonary channel blocked because there is pulmonary stenosis. Okay, this is the heart. Suppose this is the heart. This is the heart. There is A2, aortic, there is A2 and P2, sorry, ulta. This is the heart. So there is P2. This is the P2 area. This is the P2 area. And this is the A2 area, right? And there is pulmonary. And there is crisscross manner. Am I right? So when pulmonary valve or pulmonary artery is atresia or pulmonary stenosis, that time the A2 is the only second heart sound. Because second heart sound means A2 and P2. Am I right? So when P2 is absent, what will happen? A2 will be single and A2 will be soft. When we listen our second heart sound, there is lub, drub, lub, drub, lub, drub. Because dub is divided into 2 parts. Lub, drub. So when this drub is only 1 part, it will be lub, da, lub, da, lub, da. It will be like that. You got my point? It will be soft and it will be single.
Yes.
Same situation will happen in aortic stenosis. There will be only pulmonary component. So it will be lub, bu, lub, bu, lub, bu, means only pulmonary component. There is no dub. There is lub, bu, So second heart sound will be single again in pulmonary stenosis and aortic stenosis. Okay. So this child is a Williams syndrome with pulmonary stenosis. And Dr. Bella did excellent, but she missed few basic points like thrill. Okay. I asked you why you went back. Did you finish your front? You said, yes, I finished. But actually you did not finish. In the back, scar mark, in between scapula. Did you ask Marma, Dr. Bella, where is the, oh, you did not ask anything about murmur. So you have to ask Marma.
I think that murmur is not present. So I know that in between the scapula, we look for the radiation. But when the murmur missed, so radiation was also missed.
Yes, yes. So in real exam, you will not miss because examiner will not tell you anything. You will give yourself. You will hear the murmur, right? You will hear the murmur in real exam. So I guess you will not miss it in real exam. So Dr. Bella, well done. But I found you panicked today. I don't know why. You are very confident in other mocks, but today you are very panicked. I don't know why. So don't get panicked. Your exam is in next month. So don't get panicked. Okay. My advice is you did well. The investigation part, the management part, all done. You gave cardiac advice. You gave infective endocarditis to the mother. Now tell me, Dr. Bella, will you give infective endocarditis prophylaxis to this mother?
Repeat again, Dr. Tamanna.
When did you give infective endocarditis prophylaxis to this mother? When
if there is a previous history of infective endocarditis, if there is prostatic valve is there, if there is a pressure gradient is moderate to severe,
okay, Dr. Bella, I'm telling you the new guideline of infective endocarditis. It is written, they are the high risk for developing infective endocarditis. See again the guideline, but they are not the candidate. Now, giving single dose of amoxicillin is obsolete. There is no prophylaxis for infective endocarditis anymore. So what we will do, we will teach the parents that these are the peripheral sign, rash, Janeway lesion. These are the painful rash in the hand, in the feet. Okay, Osler node and Janeway lesion. And then there is a swelling of the tummy that is called splenomegaly. There will be high fever, not remitting, not going down with antibiotic and paracetamol. So this is the sign of infective endocarditis. Immediately you return back to us. We will admit the child. We will take blood culture. We will start IV antibiotic. There is no need of single dose of infective endocarditis prophylaxis. This question examiner will definitely ask you. What is the indication for surgery? The indication for surgery are clear cut. Okay. There is failed balloon. Number one, failed balloon valvoplasty. Number two, the child is having failure to thrive. He's not growing properly due to pulmonary stenosis. Number three, pulmonary and systemic flow more than 2:1. Number four, the defect is incurable. I mean, the pulmonary valves are so much stenosed that you cannot do balloon valvoplasty, or there is only one or two cusp. There is no trilaminar cusp. So cusp is defected. Then you have to do surgery. Or the defect of pulmonary stenosis merge with the VSD, like TOF. Okay, merge with the VSD. That time you can't do balloon valvoplasty. You have to do corrective surgery. So write it down: failure to thrive, failed medical treatment, failed angiogram treatment, failed balloon valvoplasty, pulmonary and systemic blood flow more than 2:1. The child has defect near the valve, like TOF, and there is cusp defect. I mean, there is not trilaminar cusp, not semilunar cusp, different types of cusp defect that we cannot do balloon valvoplasty. Okay, Dr. Bella, these two questions examiner will ask you. Indication for surgery, when you will do balloon valvoplasty, as you said, more than 40 millimeter of mercury pressure across the valve. And then they will ask you about infective endocarditis prophylaxis. Okay.
Thank you very much. Thank you very much. Valuable feedback.
You are more than welcome, my dear.
Giving me
More
the
than welcome.
chance. Thanks.
So anyone has any question before we go? because we finished our meeting, we did 4 sessions today, 2 communication, 1 history, 1 clinical. I guess this is more than enough for today. And if you liked my session, if you liked my teaching, please, you can join our group, or not, you can message in our group, or me personally if you need anything, any course, any advice, okay? And I do often this meeting, like every week or every fortnightly, I do. So you can join, you can share the group link, okay? And all the best who have exam in April and May. All the best for you, okay? Thank you.
Thank you.
Thank you.
Thank you.
Thank you, ma'am.
Thank you very
Allah
much.
Hafiz.
Thank you.
Thank you,
Allah Hafiz.
doctor.
Allah Hafiz. Thank you. Bye, everyone. Thank you.